Morning, folks.
Good morning. I'll be on camera in 5 minutes.
Thanks, Ebony.
Good morning. Good morning.
Good morning, folks. We will get started in just a minute. I'm just looking to make sure we have all the board members. Well, why don't we get started? Good morning, everybody. This is Diana Bianca with Artemis Consulting. Welcome to the second day of the Oregon Health Policy Board's annual retreat. We're going to start with just a quick roll call, and then Clarice will get us started. Let's start with David.
Here.
Brenda.
Good morning. I'm here.
Oscar. Maybe not yet. John.
I'm here.
Is Bill with us yet? Okay. Sandy.
I'm here.
Great. And Ebony, I think I heard you on the phone.
Yes, I'm here.
Great. Thank you all. Good morning again. And Clarice, I'm going to turn it over to you to open us, and then I'll do a quick review of the agenda. Oh, and there's Jessica. Jessica. Great. Thank you. Good morning. Go ahead, Clarice.
So welcome back. Glad to see your faces, second day. Yesterday we reviewed 2021, the work that you had accomplished, all the things that you had done. And so today we're starting to take the look forward, what's coming in 2022. We want you to keep the iceberg in your mind, the system iceberg in your mind, and the questions of, that accompany it. What about the decisions that you're making and the ways that you're going about the work? How is that interrupting racism? How is that not replicating racism and injustice in the, I know I should say in the Oregon Health Authority, but it's broader than that. And we all know that because the systems intersect, it's broader than that. We also wanted to just take just a quick minute to see if you had an overnight reflection, if there was anything that came up for you as a result of the conversation yesterday around systems.
I'll just say, reinforced my appreciation and gratitude for the staff and for your work, Clarice and Diana, around just a preparation of what yesterday meant and what it took, I think, behind the scenes for everyone. And my reflection was a little bit more hopeful around what's possible. Yeah, so that's, what came to me last night. Thanks.
Great. It helps not to be the Debbie Downer, so thanks, Brenda.
Well, and, I think someone characterized it this week. Someone said they're going to take a page out of Ebony's book and, speak courageously and boldly. I think, again, what I appreciate is, being able to see action and intention. I think that that's awesome. I've been in this work for 24 years, and I reflect 10 years ago, 15 years ago, 20 years ago, and I'd say that OHA has come a long way. And so I'm more than hopeful. I know that we are gonna start making gains and start seeing that impact, and we have to be patient, and we have to be thoughtful and methodical, so that then it can be successful onset. And I think I think the other piece is, what I want to be able to do and what I commit to is bringing authenticity into the conversations, just because, just keeping it 100% real. And I still feel like I'm new to this board. And, just like I'm sure many of us, people, come to me and share their thoughts of our work and our role. And one of the things that I feel like I hear is that folks feel like we are a performative board. And so, I don't know what to do with that. And, I'm not sure if others hear that. And so, I just want to put that forward because I think that's some of the, the root of the iceberg too, that I'm trying to think about in this space. So I know I'm being rambly. So yeah.
Zora Neale Hurston reminds us that performance, doesn't get us anywhere. So thanks, Ebony. Any other, John? I see you.
Yeah, I think I heard several folks emphasize that it was on us white folks to figure this out. That we shouldn't be sitting around waiting for vulnerable folks to solve this. And I agree with that.
Well, thanks, John. Putting you on speed dial.
I think one of the things that I took away from the retreat last night is just, and also even the systems change article, is the importance of relationships as we do this work, to do this work effectively and to do this work, intentionally. Definitely kind of got that also from the morning session with the committees, and particularly, having to do this work during the pandemic and virtually, and like how it's tough to build those relationships in a virtual setting. It's tough to build those relationships while we're, working from home or in our home offices. So yeah, like the importance of like, how do we build these relationships when we're all so apart?
Great. Yes, Oscar. Yes. The relationships are we don't have them. How do we talk? How do we have real conversations? How are we authentic if we don't have a relationship? Thanks. Well, as we go, again, you don't have to put anything in the room right now. The point is really just to keep the conversation, keep the notions of it alive. And yeah, as we go through today, the question will be, how are the decisions that you're making? How are the actions that you're taking? How are the plans that you're making really serving to the best of our ability? Because we're human and we're fallible and, we'll mess up, but to our absolute best, interrupting racist practice, racist policy, towards a different day. So let's get to work.
Thank you, Clarice, and board members for getting us started. Just what today looks like is we're going to hear from and talk with Pat and Leanne first thing this morning. Hear some of the work that the agency is doing focused on equity through anti-racism efforts. And we'll have a pretty long discussion there, and really want y'all to be thinking about how does what you're hearing from the agency, how does what you're hearing, what you heard yesterday from the committees, the conversations we've been having, how does that inform your priority areas for the next year? And so you have these focus areas, and we want to, we're going to talk about each one of them, the committee work, cost of care, health coverage, and thinking about, and health equity obviously running throughout. And how does what you're thinking about, how does the experience of the last year, how does that inform the work moving forward? So that's really where we're going to be today. And then at the end of our time today, we have recognition of the leadership transition that David mentioned yesterday, and then any final items for discussion and wrap up. So again, this is your time, this is your retreat. Let us know if things are going too fast or too slow. And we look forward to your participation in the discussion today. So with that, I'm going to turn it over to Leanne and Pat, who are going to give us the agency update, and then we'll have time for conversation.
Great, thanks so much. Leanne and I are going to split the time. I'm going to spend a little bit of it just giving a little bit of historical context and some of the recent past of where we've been and how we've been approaching the work, and then turn it over to her to talk in some more detail. And I think really what we're responding to is the question, what's our plan? It's great that we've got a strategic goal of eliminating health inequity by 2030. Where are we going? What are we doing? How are we trying to organize the work to be able to do that? And to be able to answer that question and talk about that, I really kind of need to take you back a few years to about 2017. And for a moment, I think with Clarice's indulgence, I need to replace the iceberg with the dumpster fire. And really think in terms of where the agency was and what we were trying to get our arms around and what we were trying to focus on. We had a lot going on, and a lot of it wasn't great. We had various controversies. We were mired in a backlog of redeterminations. We were fighting over CCO rates. A whole bunch of negative things were happening. And it felt a little bit within the agency like we were just kind of pinballing from one crisis to another as we tried to move through that work. So one of the first steps that we took to try to get control of that was adopting a performance management system that we continue to use today. And we've presented this to the board before, but I think not in quite some time. And the general idea of this system is to start with, what is it we're expected to do? What are we trying to deliver for the public? What are our outcome areas? Then how do we know whether we're delivering those? What are the measures for those outcome areas? And then most important, I think, is what are the processes we have in place in the organization to make progress on those outcomes? And how do we know whether those processes are healthy or not? And if you think of just sort of a simple traffic light, green, yellow, red, where are we with most of those processes? And in government agencies, often what happens is you have a process that was green that all of a sudden goes to yellow, and nobody notices. Nobody notices that something fundamentally external changed. Something as simple as somebody retired who was doing something important and nobody handed that work to anybody else and nobody noticed. And what often happens, back to the analogies, is you kind of move without anybody paying any attention from green to yellow to red to dumpster fire to legislative hearings in the front page of the Oregonian and all kinds of bad stuff. And the idea was to do a much more intentional job of trying to keep track of that work. Now, I bring all this up because when I think about our work to be anti-racist and to pursue health equity, that's really where some of that work changed some of its direction. I talked about outcomes and outcome measures, and one of the conscious decisions we made was to not do what I think frequently gets done, at least in Oregon, if not other places, which is bury a lot of sins by rolling up statewide totals and not looking at subpopulations. And so instead of having top line measures for different kinds of community health measures that were just statewide averages, we actually had top line measures that broke those out by race, ethnicity, so that if you opened up a page of measures, you wouldn't see a whole bunch of greens or maybe some yellows that were burying a bunch of reds. You would see those reds front and center in front of you, so that we would see the disparate health impacts at the very top level of what we were trying to measure. Second thing we did in that was really have a thoughtful conversation about, well, I'd like to believe it was thoughtful, of where health equity should live. Should it live as a value? Should it live as an outcome? Should it be included in processes? And we basically decided all three, that it was an important enough topic that you couldn't just sort of pigeonhole it in one place, that it had to be it had to be woven throughout the work that we were doing so that we were capturing health equity processes. We were looking at equity outcomes. We were thinking about equity as a value. And that's how we built that, that performance system. And, I think I think that system did one thing that it was supposed to do, which I think it kept us out of dumpster fires because we were able to keep an eye on processes. But I don't think it by itself did a very good job yet of delivering equitable health outcomes. I think it was a step in the right direction, but it was itself insufficient. Fast forward to 2019, actually fall of 18, when this board adopted the health equity definition that we've been using ever since. I think I've got that date right. And to Ebony's comment, I would really disagree that the board is performative. I think steps like that health equity definition have animated the work that the agency has been doing ever since that point. That's not an isolated example. I think there are lots of examples where the board has really pushed us in different directions than we would have gone otherwise in doing the work. But that definition was established. And we've talked a lot about the ways that it breathes life into our work, but for me particularly, the notion of allocating and reallocating power and resources, I think, is one of the most important elements of that. And I think that's really animated a lot of work that's occurred in the agency. We then began a strategic planning process in 2019. And a key feature of that process was to start with what I think was a good round of authentic community engagement, not sort of gathering together usual stakeholders, but really going out at a retail level into various communities and engaging and asking basic questions about what do you need for your community's health to be better or to improve health, or a variety of ways to phrase that work. And that became the raw material of the strategic planning process. And really, when you boiled down what we were hearing from communities, it was we need the system to be less racist. And so we really need a fundamental dedication to health equity as the work of the agency. And so we came out of that process at the end of 2019 with a commitment to the long-term goal that we've all talked about a lot, of eliminating health inequities by 2030. And that really took health equity, which had long been a value for the agency, and took it from being a value, something that we pay attention to while we do the work, to being the work itself, the point of what we are all gathered to do, and the objective that we're trying to establish. That got us to the end of 2019, and a funny thing happened at the beginning of 2020, known as the coronavirus pandemic. And that strategic planning work would have moved on to the next step, which I think is kind of inherent in the question, which is, okay, so what are the buckets of work you're going to go do? What are the measures you're going to use to know if you're closing those gaps? And that work of necessity really kind of ground to a halt for the better part of a year, while we threw all the resources in the agency really directly at the pandemic. Not without health equity issues, obviously, though. The pandemic itself helped reveal or illustrate or shine a brighter light on the existing health inequities in the system and how those inequities played out in the pandemic. People without health insurance, we've talked about, isn't an end in and of itself. It gets you access to care. In Oregon, ideally, it gets you access to high quality primary care. High quality primary care provides a relationship that in a pandemic, we know, can provide access to testing, to support for quarantine and isolation, ultimately for vaccines, those kinds of things. And we saw those inequities play out and become a major focus of how we tried to reorient the work. And I think we actually, over the course of time, did a pretty good job of reorienting that work. We closed inequities in vaccine distribution by 50% or more over the course of about 9 months from last spring to about now, or a couple of months ago. Today, Black Oregonians and Native American, Alaska Native Oregonians are more likely to be vaccinated than white Oregonians. Same is not true for Latinx Oregonians, and that's an area we continue to work on. But I think we've seen those kinds of things play out over time in the course of the pandemic. I think over that time, what that health equity strategic goal has served as is not so much a strategic goal with strategic work behind it, but as a guiding principle for the work that we have been doing. And you see that play out not just in the pandemic, but things like for all of its fits and starts, the Measure 110 work, where we've really designed who's at the table making decisions and how does money in that system get allocated in a completely different way than we would have before. It's played out in our relationship with the legislature, and what was originally Cover All People, and while I was at it, its name got changed, so I keep forgetting. I think it's Healthier Oregon. Traditionally, we would have gone to the legislature and said, well, you're talking about $100 million. The real cost is $400 or $500 million, so we can't cover everybody. So here's who we recommend you cover. And instead, the legislature, and we ended up with a structure that came back and said, go to the community that's going to be served by this and engage with the community about who they think should be covered by this. And through that process, came up with a recommendation to basically kind of start at either end, older Oregonians and younger Oregonians aging out of Cover All Kids to be able to maintain coverage in the system. And there are lots of other examples, I think, of how that guiding principle element has played out. Now we're at a place where we're going to pivot to really thinking about what's the work, particularly between now and the end of the year, as we face transitions potentially, and want to be able to be well positioned to provide a portfolio of pieces of work. But there's lots of other work that's gone on, and that's, I think, what I want to do now is go ahead and turn it over to Leanne to, I think she's got a presentation and talk about some of that work.
Thank you, Pat. Yes. Good morning, everyone. My name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division, she, her. My visual description, Black woman with black graying hair, wearing a bright yellow sweater against a blue and green background. It is a pleasure to be back today. I appreciate so much the conversation that occurred yesterday, and then the depth of reflection that occurred, and some of the overnight thoughts as well, and very much appreciate the iceberg and how that took us into the brain space, heart space of the deep, deep change that needs to happen when it comes to eliminating health inequities and dismantling racism and colonization in the system. And that depth is critical because the approach that we have been taking for many years related to equity, diversity, equity, and inclusion, and that name has evolved over time, has been that deep dismantling and policy change at policy level. And I would, I think I'm going to offer a historical view on this. I've been here almost 11 and a half years, and very much appreciate the leadership of Pat Allen and our current leadership team, because I think what happened around 2017 is that the agency started to embrace what our work has been all along in the Equity and Inclusion Division, in the Community Partner Outreach Program, in Tribal Affairs, the matters, ideas, and activities that we've been bringing forward over and over again with very little support. And under Pat's leadership, we got that support. And under the this leadership team, we got that support. And if you recall, a meeting or two ago, Dave Baden, our Chief Financial Officer, was here, and he put on the record that not only did we not listen to community, but we didn't listen to our own internal partners, meaning Community Partner Outreach Program, Tribal Affairs, and Equity and Inclusion. And that is the difference that's being made right now. And it is truly a matter of leadership. And it is truly a matter of people of the majority culture of the population with current power stepping up to do work differently and to follow the lead of community, to follow the lead of the subject matter experts, not only within the agency, but outside of the agency as well. So I say this with a great deal of gratitude for where we are headed and the leadership that is finally in place with Pat and team to begin to really bring to really, as I said yesterday, to enact the values that we have been espousing. Next slide, please. So always acknowledging the gratitude of the people who came before, the people who are here, and all that which is life-sustaining for us, including our planet Earth. And we are never, ever alone in our strengths or accomplishments. And so a great deal of love and gratitude for tribal populations, tribal communities, tribal nations, who 530 years ago were made to be disenfranchised from culture, from language, from space, from place. We are on stolen lands. And we can never forget all that came before us in the centuries upon centuries of this legacy, not only of oppression, but the legacy which came before those 530 years of connection, of wisdom, of strength, and of resilience. And that's what we are working to amplify and to leverage, to come together in this work so we can finally make a difference and end this 530-year legacy of oppression and colonization moving forward. Next slide, please. So I want to give you a little bit of background, only because I know we have new members of the board, and I just think it's really important for there to be a foundation of understanding and a reminder as well that the Equity and Inclusion Division actually grew out of the public health legacy of the Minority Health Office. And this work actually started in 1992 in the state of Oregon in the public health department. And then about 12 years ago, it was as we moved towards the creation of the Oregon Health Authority, the work moved out of public health and became a broad-looking effort across the entire agency. At this point in time, we've moved into 16, maybe close to 20 functions that the Equity and Inclusion Division carries out, both for the Oregon Health Authority and the state of Oregon. And 8 and growing of those functions are state or federally mandated. So this work is extremely critical to our opportunity to seize the moment and move forward to eliminate health inequities by 2030. As I've said, we're looking at deep systems change, which takes time. When we're looking at deep systems change, it takes time for us to see those outcome measures, to see those actual disparities on paper shift. But what we do not want to lose sight of is that this is truly about the inequities that exist. And we've got to have deep systems change to counteract those inequities that are built into the system. And so policy is a really critical piece of our work. We also have a very explicit strategy to diversify our locations in statute and policy. In the 4-year span of a previous federal administration, we saw multiple offices close because there was one line in one policy or one state law that said this work will exist in this location. The only thing that had to happen was remove that from state law, and that work was out the door. So we have actually worked intentionally to be sure that we are in multiple areas of statute, in legislation and in law in the state, and that we are also carrying out those some federal functions as well. So all that said, we are really minimal when it comes to direct service. We are not direct service. We are once again about systems change. Right now we have, when we talk about 16 to 20 functions, and we have a team of 22 people doing that. And that has been such an inequity in our agency. And over the last 3 years, that has shifted through the leadership, as I have stated previously this morning. And we're expanding by more than 44 people, which will move our division up to more than 70 plus people ultimately to carry out this work with greater capacity as it is intended to be and do within our agency and across the state of Oregon. And very critically, we have always moved from being led by community. Our job as government is to follow community, to follow the lead, especially those most harmed by inequities. And this that has been a basic principle of our work in the Equity and Inclusion Division and the work of the equity and the discipline of equity and inclusion. And I've said this before, it is a discipline like human resources, like communications, like budget and finance. This is a discipline as well with a body of work, research, theory, and application. And what we're doing is moving that once again, from espousing to enacting, from theory to application to change. Next slide, please. And this is a list of all of the policies and programs that are within the Equity and Inclusion Division, that move out throughout the entire agency and move out throughout the entire health delivery system to make those shifts that we are talking about. Traditional health workers, healthcare interpreters and language access, I'm just going to read these: Americans with Disabilities Act, Civil Rights for the Workforce and for the Public, Race, Ethnicity, Language, Disability, Sexual Orientation, and Gender Identity Data Collection Standards, Equity Advancement in the Workforce, used to be called Affirmative Action. We're evolving that to Equity Advancement. Our Health Equity Metric around language access for coordinated care organizations, Regional Health Equity Coalitions. Next slide, please. Cultural competency and continuing education. We manage the equity plans for coordinated care organizations. We conduct health equity research and assessment. We have a program called Delta, which is Developing Equity Leadership Through Training and Action, which is a statewide program that brings together providers, community members, coordinated care organizations, in a 9-month training around equity leadership. We provide technical assistance, legislative development and review, and of course, our foundation is community engagement. Next slide, please. So all of this sort of converged in 20, as Pat stated, 2018 and 2019. And this definition came forward from this board through work from the Health Equity Coalition and the Equity and Inclusion Division. And you know this, I don't need to go through it, but what I will say is that so there's really what we're working with, as we work with this more and more in the agency, we're really starting to underscore and amplify the fact that there is action inherent in this definition. That action, ongoing collaboration, and it's collaboration for the sake of making change, not collaboration for listening and then setting aside what we get, but really how do we then integrate what we are getting from regions, sectors, and very importantly, tribal governments in our tribal consultation work that comes out of Tribal Affairs and Director Julie Johnson. So that piece is, there's action inherent in that. There's action inherent, and Pat has talked about this, in that distribution and redistribution of resources and power. And there's action that's inherent in recognizing, reconciling, and rectifying, and I would actually also add restoring. When we talk about this historical and contemporary injustices, we must restore justice, and we must mitigate the 530 years of oppression and colonization in this work. Action is inherent, and we are taking this extremely seriously as an agency. Next slide, please. So you're aware of the OHA strategic goal as well, to eliminate health inequities in Oregon by 2030. And what's critical here is that it's important. It was absolutely important for us to set the intention, because what this does, it creates the accountability for us in our daily work, day in and day out. Neutral is no longer sufficient. Certainly detriment is not acceptable. And we really have to be moving affirmatively. Every decision, action, allocation of time and resources and staffing must be moving us towards this 2030 goal. Every policy change, policy, or going back into policy and changing that which has been, where there has been injustice baked in, all of that work, it's extremely, it's extremely overwhelming. People say, can we get there by 2030? I honestly, I have to say, I don't know. And what this does, more importantly than anything, is set the intention. So we're holding ourselves accountable day in and day out. And without this goal on paper, without espousing this, we will not be able to enact it. Next slide, please. So some of the activities that we are doing that I want to highlight, there's just a few of many. I've already highlighted all the different programs. And some of these are very familiar to you. Our health equity metric, you know that was a 2-year grind working to get that moved forward and approved. Appreciate the help and the leadership of the Oregon Health Policy Board in getting us there. We're still struggling. We're still struggling with health equity metric, as well as going down a few lines here, health equity plans. We really need your help to help us hold the system accountable, and we need your help to get those barriers out of the way, because there is still resistance in the system, and we still get resistance from the broader health system, from some coordinated care organizations, not all. We've got also some great advocates out there as well, and our work and getting to that 2030 goal is going to be absolutely contingent upon the cooperation, the collaboration, and the willingness to share the data and the information that we are requesting as an agency of these organizations. So if you could plant that someplace, we really need that help. I also want to just highlight the health equity grants and COVID-19 response. This was an extreme $45 million, which we have never, ever had any inkling of having those kinds of dollars go out via a health equity grant. And it was really led by the Community Partner Outreach Program, Tribal Affairs, our division, and the budget and fiscal folks, as well as our external relations team. So that was an extremely, and we're still getting the gratitude from community-based organizations and not-for-profit organizations that have said we have saved lives with these dollars, and that this is where sometimes that direct service piece is really rewarding, and we can see the fruits of our labor much more quickly than through policy development. You also know that we're working intently in behavioral health with the 1115 waiver, Healthier Together Oregon, which is the state health improvement plan, as well as the Healthier Oregon program, which used to be Cover All People. So these are just a few of some of the activities that some of which are deeply ingrained in the system, and have the greatest opportunity to dismantle that which has created these inequities.
And
yes.
Leanne, just quickly, the health equity grants also involved the newly created community engagement team in public health, and that sort of new structure, I think, is an illustration of how we're changing the organization to do this work better as well.
Right, Pat. Yes, there was a broader, yes, also behavioral health and public health also had grants, and this is the specific health equity grant piece here. And thank you for that. Yes, that broadening. Absolutely. Next slide, please. And so a few of many and many more. We have actually, and this is to Pat's point earlier around our moving forward towards that 2030 goal. And we've actually identified 40 areas of work already that are moving toward the 2030 goal. So we have a really strong foundational opportunity for this work to make a difference. And I've often said, and Pat has heard this, that we just need to get the resistance out of the way. We have almost all the elements we need to be successful in this work. We've got to get the resistance out of the way, systemic resistance, individual resistance, and that is real. And I recall board member Clark saying yesterday that if we as brown and Black people could have ended racism, we would have done it long ago. But it's the resistance that's really getting in the way. And that comes very directly and also very indirectly. I have a colleague that calls it not the tsunami, but the riptide that rips our feet out from underneath us in this work. And the system is very insidious in how it protects itself. And so each and every one of us need to be an agent of moving the system in the direction towards that 2030 goal. Also, we are working right now with the possibility of assessing our strengths and our gaps, and to complete the roadmap to get us to that 2030 goal and stay the course. And finally, I will end by saying that, and I appreciate Dr. Santa saying several months ago that this quote was very impactful. How will we know when we're there? We will know when the community tells us that we are there. And so our work, as you know, is very much community focused. It is very much systems focused. And because we live in the United States of America, there is built-in resistance to this, implicit and explicit. And our plea is that we all work together to get that resistance out of the way. And if we can do that, are multiple areas of work that we have identified moving towards the 2030 goal can really fulfill the full impact of the work and fulfill eliminating health inequities in the state of Oregon. Next slide, please. I think that might be it. Yes. Thank you. Thank you.
Leanne's discussion, excuse me, of resistance reminded me of one really important body of work that I neglected to talk about in my kind of overview of how we got here. And that's our investment in anti-racism in the organization. At the very outset of the strategic planning process, we had the leadership team go through a 2-day facilitated anti-racism training that was then followed up with what continues to this day of ongoing coaching from outside facilitators who helped us try to deal with those issues and deal with issues of fragility, race, resistance, all those kinds of things. One of the things that we did over the course of 2020 and 21 was reflect on the fact that we weren't going to make very much progress on achieving the strategic goal if we didn't actually transform the organization itself and really focus on anti-racism as a key element of what we needed to do with the actual human beings in our buildings and doing our work. And so we've made a major investment in that same facilitated anti-racism training across the agency. And we've had hundreds of people that have engaged in that training. And now we're beginning to pivot to the really hard work about how do you translate that into accountability? Having people really be held accountable for the work that they're doing or not doing, for the attitudes they bring or don't bring to the table. It's really challenging work, and is one of the things that we're going to be talking about as a leadership team as we do a retreat next week of what's that really look like? What do we need to do to be able to hold ourselves and each other accountable for the transformation that we need to have occur in the agency? I would say the transformation has begun. I've used the analogy lots of times of turning a really big ship, and you crank the wheel for a long time and nothing happens. And you finally begin to see after a while the bow begin to turn. And I think we're kind of at that phase, but there's still lots of opportunity for resistance, for failure to do the things that we need to do. And we're really trying to power through that. With that, Diana and Clarice, I think we've left some time for questions or reaction or discussion.
Yeah, absolutely. Thanks to you both for setting it up, for giving us the look back and forward, bringing the hope. So, for the board, questions about what you heard, comments? I see John, I see Sandy, I see Brenda. All right, so John and Sandy, and then Brenda and Ebony.
Yeah, Leanne, I just thank you for your comments. We're 58 years and 2 days from Martin Luther King's assassination. And your comments reminded me of his speech from, I'm not sure whether it was a Montgomery or Birmingham jail, to white ministers, expressing his concerns about their lack of support and lack of understanding of what was going on. I think you're channeling him. And I think that's just terrific. And Pat, I think it's a terrific that OHA has enabled this to happen. And it just needs to keep happening and need to keep channeling those thoughts.
Thanks, John.
Thank you.
Sandy.
Yeah, this is to Leanne. So, the current rec structure had nothing in Eastern Oregon for that governance. So how has that changed?
Mm-hmm.
Number two would be, the traditional health worker model, when the tribes had worked with both your office, the Oregon Health Authority, Julie Johnson, Northwest Indian Indian Health Board,
Mm-hmm.
Umatilla tribe, all 9 tribes of Oregon and with NARA. That was very successful for us because it was changing kind of some of the dynamics of how healthcare was delivered or actually communicated with our tribal members. It kind of broke down the barriers. Instead of, say, me going and seeing a mental health worker or MSW that, you know, they're going by the books, and this is just not how we work as Native people. With the bill being passed last year, how is that structure going to change? How can we develop more programs to break down that barrier where sometimes we are not siloed. We're on one building. Sometimes you're a mental health worker. Sometimes you're you're a A&D counselor. Sometimes you're just a person, you know, to listen. But how can we break down those barriers so that we can deliver a better wraparound service to our community members? Number one, I may be a community health worker or and this is what this is based off of. The traditional health worker is really based off of a community health representative that the Indian Health Service did, you know, back in the day. So how can we change that model, not only in the Native community, but other ethnic communities to progress? I mean, sometimes you don't have enough mental health workers, you don't have enough alcohol and drug counselors to help produce the need in the community. So, and you know, with COVID, there's been so many younger people having to do distance learning and not interacting with other students, whether it's just falling behind in educational, their educational progress, or not having that that opportunity to play with other kids. And I see it increasing, not, you know, all over the place. It's not just in Oregon or the Native American community, but that breakdown and trying to catch kids up is going to be tough. So I guess those are two questions, because I really want to move forward. I mean, I want to go from womb to tomb for providing traditional health workers and getting our kids from the very beginning and changing that dynamics for them. So,
yeah, thank you. And agree with everything that you've said. And I just want a clarification. Were you speaking about the Regional Health Equity Coalitions? That question? Was that the first part of your question?
Yeah, that was the first one.
Right.
You know,
Okay,
you have
right.
it in, not in Eastern Oregon.
We have, well, actually, we do have.
Oh, you do?
Yeah, at that time. We do have one in Eastern Oregon. We provided a couple of exploration grants, one to Eastern Oregon and one to the Confederated Tribes of Warm Springs, so that both those areas had opportunity to not have to have deliverables, but they could do an assessment of what they needed. And so there is that. And because the Regional Health Equity Coalition model is designed first of all, for self-governance within those entities. Those entities might be anywhere from, from a section within a county to several counties. And it's just a matter of how regions want to organize themselves. And I think the hopeful news here is that we've worked on an expansion plan for that, because the goal is to have regional health equity coalitions across the entire state. So this next round of the long session, legislative session, will actually, there was legislation that paved the way for that, and this next session will solidify that. So so that's what we are working on for sure, because it has been a successful model, but it's been a limited model, and we're changing that. We're working to expand that. And then regarding the traditional health worker program, yes, right now we're working with Tribal Affairs, Julie Johnson and her team, to hire the the Tribal Traditional Health Worker Coordinator. And that is one step towards this very large endeavor that you're speaking of, Board Member Sampson. And we've had to move step by step in this. And I think that also that the behavioral health work that's occurring, getting more information around that to this team. I know you've had reports previous, but I think part of what we need to be doing and part of where we'll be heading in this 2-day work session that Pat spoke about is how are we going to actually get beyond our silos within our agency so that what you just spoke about, because it includes our behavioral health unit, includes tribal affairs, it needs to include our equity and inclusion unit, traditional health worker program, is how do we start connecting those dots? Because the seams that we create are seams that are artificial in the broader state and broader community. And so we've got to get beyond that. And we're not there yet whatsoever. I also would add that Healthier Together Oregon, the State Health Improvement Plan, is really an opportunity to get beyond the health domain into accountability with education, Department of Education, transformation, criminal, what I call now the criminal injustice system, not justice system, but all the different domains where health is, where that impact health. And that Healthier Together Oregon will hold that greater accountability. And the Public Health Division did an excellent job working to be sure that all those domains were representative, that are aligned with the social determinants of health, and that community was a part of that development as well. So I think it goes back to just being really poised at this position of great opportunity to move in a more comprehensive direction. And I will still put my plea out there. We got to get the resistance out of the way.
Thank you. And then just one last comment. I've worked with Pat since he came on board, and I remember working with or sitting with him in Klamath, Oregon at a retreat. And he told me, Sandy, things were going to change. And I really do appreciate everything he's done over the last, 6 years, 7 years, Pat? I don't know how long you've been there. I've been through
4.5, but it seems long.
Yeah, but I've been through many OHA directors, and I do really appreciate his stamina and how he's been a mover and shaker to make things work. So just wanted to say that. Thank you.
Thanks to you, Sandy, for that. Brenda, you're up, and then Ebony.
Actually, I was tracking. I think Ebony's before me. Thanks.
Okay, great. Thanks.
Well, thank you, Brenda. No, I just, I think that, as Pat has, as Director Allen has stated, and as Director Johnson has stated, I think that this work is monumental, and I think that it's easy to kind of have the challenges and the elements of where we are not at in the forefront, and so we don't get opportunity to be able to speak to or show or visualize the monumental effort. And so I think I just want to thank you and appreciate the intentionality, moving from it just being value-based, I think, as Director Allen spoke to it being a part of the through lines of all of the work. And of course, we still have a long ways to go, but I think it does make a difference when we're able to talk about where we want to go with what we've been able to accomplish thus far. And so I just want to highlight that, recognize that, and just continue to commit to making sure that we are highlighting what's happened and what's been accomplished as we move forward. So I just wanted to say thank you and great work. Thank you.
Thank you.
Thanks for lifting that up, Ebony. Brenda.
Thank you. Thanks, Pat and Leanne. That was such a great reminder and presentation on where we've been. So I echo Ebony's thoughts of, appreciation around our progress. I have two questions. One is related to the extent by which we think we have conversations within the agency that, and within our committees or even at the board, that we're actually talking at that lowest level of the iceberg model, at the mental model itself. Or how often do you think we're actually talking about the upper tier or the event, or we're speaking to the issues without understanding really that, I don't know, that open-hearted part where we're willing as a state or willing as an agency to be heartbroken in order to shift mental models or belief systems? So that's question one. I asked it yesterday in part of our breakouts with our committee members, like, to what extent is our committee actually having the belief conversation instead of just speaking to the issue or the concern or the obstacle? So how do we do that? That's my first question, and then I'll ask a follow-up.
Yeah. I so appreciate the question, because it just hits the point. It drives the point home. In our outcome results driven culture of the United States of America, we want to go so very quickly to what did the data say? How come you haven't moved that needle yet? And it has been, I'm just going to be really honest, it's been really painful to be in the space where those of us who have been most harmed and those of us who are doing the work from the standpoint of the discipline have said, we have got to get to a different conversation. We've got to get to a deeper conversation. This is about values and belief systems. And it is about the fact that we have been on these lands for 530 years, we have been conditioned to dehumanize. And that still plays out explicitly. And typically in our environments in government, it's very implicit, because nobody wants to admit that they might have a racist thought or tendency, right? But the actions still occur. And it often rides under the radar. So this is where the anti-racism work that Pat talked about a bit ago has been extremely important. And it's extremely controversial because there is also a belief that we shouldn't be in the business of belief systems, but there's no other way. And at the very least, what we have for some people are just simply accountability measures where we say, in the 8 or 10 hours that you are here, this is the expectation. And in doing that, we've also seen conversations where people are at that kind of surface level. I just need to do the right thing. And then all of a sudden something happens, a realization occurs, and that breaks open, and it does create a lot of pain and angst. And how many of us really want to run into pain and angst? Not many of us. And those of us who have been most harmed in this 530 years, we live the pain and angst every day. And it's not that we want anyone else to feel just as bad as we did or do, but we want this to shift. And we want empathy and critical thinking to prevail. And I truly believe that that's a crisis that we are in. We are in a critical thinking and empathy crisis in this nation right now. And so unless we can find those elements and probably a few others, we're lost. We are lost. And so I don't know if this is an answer. I'm just acknowledging everything you have brought forward, Board Member Johnson, and acknowledge that we have to have those deeper conversations that might be quite painful at times. And when that breaks open, we have the opportunity to move towards true community and not pseudo community that we tend to stay in, and that seems somewhat prevalent in the Northwest in terms of our politeness. And once again, it's not to create intentional harm for anybody, but we're not going to get there unless we move. We can't we've got to move into it, and that's going to be painful. There's no way to move around it. And I think there's just one other dynamic I'd like to speak to very briefly, and that is, often in anti-racism work, you hear about decentering whiteness. And the fact of the matter is that doesn't mean that there's no accountability or responsibility there. And sometimes that's the way it's perceived. Like, I'll just step aside, I'll let community come forward and I'll follow them. But there's a much deeper what's the word I want? Shift that needs to occur than that. And so we have to kind of center the fact of where these issues have come from before we can really talk about decentering and moving through.
If I could just quickly add to that, I think there's also a really painful tension between the reality of trying to change the center of gravity of the values and beliefs of an organization of 5,000 plus people and the length of time that takes. And you kind of very logically want to say, well, this is going to take a little bit. This is going to take some time, and the tension with then being able to look people in the eye who have borne the brunt of the inequity and injustice, asking you, how long? How long should it take? How long is acceptable? And there is no good answer to that question, and yet that tension really exists. And I think we're not at that tipping point yet as an organization, as hard as we're trying to push on it.
Yeah, thank you both for that reflection. That's very helpful. And I think as we, as a board, and move toward our conclusion of this particular strategic planning session, I'm interested in thinking about how we tend to all of those levels of the iceberg, and that we are by design really contemplating the length of time you're describing, the perseverance, this question of anticipating the resistance and overcoming the obstacles despite it. Like, yes, it's there. We know it's there. It'll always be there. And how do we stay after it such that we can continue to do the good work moving forward? So I guess my second or follow-up question is really, if we've got the vision and the next step is to give us the tactics, as you described, Pat, the buckets of the strategic plan that help us see the actual concreteness of the progress. And then as we think about the obstacles, are there obstacles besides the ones that exist in each of us as people? Those, yes, continue to do our individual work. I think the work then in groups and the belief systems around, is it okay for this agency to acknowledge how imperfect it is, how we are imperfect humans, right? How often do we say that out loud? I hear you do this, Pat, effectively and often. And I think, how do we normalize that so that that brave space or that courageous space that Ebony was talking about, or Leanne, that you're calling out, is something that we can really trust, that these conversations that go deeper and deeper into the mental models as we're describing are so normed that then the activities simply follow. So it's more of a plea, I suppose, maybe Diana and Clarice, as we think about what is the strategic planning process and how do we package the work with the agency moving forward, that we tend to all of those levels. Yeah, thank you.
Thank you, Brenda, Leanne, Pat. Thank you for your reflections, contemplations.
Thank you for the opportunity to share freely. Appreciate that very much, because that's the only way we can do this. Have to be honest.
What does OHA need from the Oregon Health Policy Board in order to do all the things, right? To break down the silos, to go deeper, to pay attention to all the levels of a system, cross systems. What does OHA need from the Oregon Health Policy Board?
I'll jump in. I think one of the huge values that the board can provide is a degree of continuity at a time of transition, and holding the agency accountable to doing the work necessary to make progress on health equity. I firmly believe that it really doesn't matter who's going to get elected governor. I don't think anybody who gets elected would say, well, I'm against health equity. Let's pursue health inequity. But I think there are lots of opportunities for shift in focus or intensity or risk taking or those kinds of things. And I think over that time of transition, the board could be very helpful in being the vehicle that holds us accountable to continuing to focus on that work and bring back concrete as we talked earlier, buckets of work that'll help accomplish that.
Yeah, thank you. And I agree 100%. And we need that cover, right? When I talked about resistance in the broader health system, we need cover. When we push for data to be public, revealed. How well is the system doing related to that health equity incentivized metric on language access? How well are coordinated care organizations doing when it comes to the health equity plans? And that cover is critical. The more we push as an OHA, the more tension there could be in the broader system. And that's something that I know I would appreciate, and that continuity that Pat spoke to as well, as things shift potentially. Well, they will shift. And what I know Pat has been working to do is say, how do we get this embedded? How do we get this work embedded so that it doesn't just go away when people go away? And so this board is critical in that continuity.
Leanne, before I get to Kirsten and David, could you just take a microsecond and talk about what you mean by cover? What would that, knowing that you're not going to have the complete everyday 24/7, but
right. Yeah. I don't expect bodyguards or anything like that.
Okay.
I've had bodyguards before doing this work in my life, when I've been out in public, because that's how controversial it can be. When there's a push related to health equity work, anti-racism work, there's a push back. And we're moving, I think, beyond the time where that pushback works to discredit not only the work, but the people doing the work. And the system will corral itself around the pushback rather than the change. And so many people within the agency and many people within our equity inclusion team, within our community partner outreach program, tribal affairs, have been discredited. There's been an attempt to discredit them because sometimes they can't discredit the work, so they work to discredit the people. And so anyway, so that's what I'm speaking of, is that trust. We need to be trusted that we know what we're doing. OHA knows what it's doing. It's pushing for a shift in the system. And this is the only way that we will reach the mission vision of the agency for optimal health for all, is to move forward with the health equity and anti-racist, anti-oppression, move the barriers, dismantle the system approach. That's threatening to people. And we need to know that we've got the support of leaders such as you in this system, and for you to be united in that and help us, whether that's providing cover or helping move things out of the way so that we can do our work. I don't know if that sheds any additional light. And I, never am I saying this, that everything's bad and all people are bad. It's not that. It's the system protects itself, and when left to its own devices, it defaults. It defaults. And in that default, there's sometimes a desperation that creates the need for cover.
Great, thank you for that. Yep, systems are built to be durable. Otherwise, we wouldn't have a desk to show up at. And it gets in the way. Kirsten and then David.
Well, I really appreciate the question that how you kind of introed this question, Clarice, because that was exactly where my mind was going of like, okay, I hear the kind of requests to address how do we move resistance out of the way? And my mind starts to go places about what role the board could play in that, but really I appreciate this exploration of what that means and hearing directly from the people in OHA doing the work about what you need from this board. And so I guess I just want to say that I'm listening and that I do think that OHPB has a role to play, and I'd like to see us play that role in to use your language, Leanne, in providing that cover or providing that support of saying like, yes, this is important and essential, and without it, we can't get where we want to go. And so earlier, Director Allen talked about kind of showing the data, making sure that the green bars don't hide the reds underneath. And that's been kind of repeating in my head of, we do that in some areas, but not all. And I can imagine for the staff people doing that work and writing those reports and deciding what gets released with the OHA stamp on it, it can be, there are times where maybe we're holding back on looking at that lower level because of the pushback that would occur. But I guess I want to say, to ask where else can we take the courageous step of going deeper and in identifying the resistance, measuring the resistance, and putting it out there and letting some sunshine address it. Yeah, so I just would like to hear more, and today and always, about how we can be supportive, and to just say out loud that, like, I think we need to be asking ourselves, where are we hiding the red bars, and how can we put that out there even when it's scary?
Great. David and then Ebony.
Well, first I want to thank Director Allen and Director Johnson for their leadership in this area and encouraging, supporting this and leading this transformative change, and Clarice and Diane for facilitating a really generative discussion. I want to take a moment just to remind the board of an important resource to help define the goals, strategies, and to end health disparities, achieve the goal of end health disparities by 2030. And that's with two really important committees, both the HEC and the FAB, Health Equity Committee and the Public Health Advisory Board, which both those committees have a new roster of people with real expertise, energy, and commitment to helping Oregon Health Policy Board achieve this goal and OHA achieve this goal. To advance anti-racism, redefine the paradigm of public health from doing the most good to the greatest number of people to ending health disparities. I think that's a real important paradigm change. And there's a lot of people willing to help, but they're looking for direction. They're looking for a charge from the Oregon Health Policy Board to contribute. And so I think it'll be really important for this board to keep that communication going with those two committees, to identify a liaison for those committees, to really enlist that expertise, that energy, that commitment, because I think it's going to create a lot of people working together to achieve these goals. And I want to make sure that those committees are, enlisted and can contribute in a way to help advance the larger mission for this board.
Great. We'll hear from Ebony and then start to wrap this section up.
Can y'all hear me okay? Yeah, I just, so many words. Look, my background is a social worker and a therapist, so I'm super touchy-feely. But I just, I sit and I look at, the faces, and Director Allen, I was just watching you, and Director Jones, I was watching Johnson, I was watching you. And it's just like, what was coming to my mind is that, this work is hard. The work is lonely, especially the work that y'all do. And then when you add this commitment to live out, moving forward to do better around health equity, racial equity, it's only further alienating. So I say that to say that I know that, there's a lot when you put yourself on the line and the risk that you take. And so I just want to, say that we realize that what's under there. And that's hard and it's thankless work at times. And so, just want to highlight that. I also want to appreciate, what you both are bringing forward in terms of what we can do as a board, and in my mind, it's like, then how do we hold ourselves accountable? And then the last thing I'll just say is that I also appreciate and hope for continued authentic conversations between the both of you and the board, because the more that we can start to step into some authentic spaces and have some real conversations, and conversations that at times can be vulnerable, I feel like that's where we start to then build relationship to get at trust, so that y'all feel assured that we have your back and that we can cover you, and that you can feel assured that we as a board are not being performative, and that again, we are pushing for action, and that we're also holding ourselves accountable. And so just wanted to say that. So thank you.
Thank you. I have one last recognition and plea, if you don't mind. We've had a lot of starts and stops with this work. I know since 1992, 93, when this was in the public health department, we've had many people that have pushed this work, and leadership has changed, and then the work goes away. And so what we're hoping is this time there will not be a stop, right? That we've gotten to a close to a tipping point for the good, and we don't want this to be a stop. And in the past, over those years, there's been progress, and then fear, and then stops. And so I also do not, so that's my plea and then my recognition is that there have been many, once again, that have come before, that have led in ways, but they have been stopped. And so I think about James Mason, who was one of the first people in the position that I'm in now, Dr. James Mason. I think about the work of Abel Gordley and the role. I think of the work of Tricia Tillman, my predecessor. And I think of Dr. Goldberg, Dr. Bruce Goldberg, Pat's predecessor, several people removed, and many others. So I want to just really acknowledge that the only reason I'm here, the only reason that Pat is here, is because of all those folks that came before that started and were stopped. And I hope that 20 years from now, people are not talking about Leanne and Pat, who did great. They had a great start, but so anyway, thank you. I just appreciate you all very much and the opportunity for this conversation.
Brenda, you gonna take us home?
Yeah, I think so. Well, I hope so. I don't know. You told me, Clarice. My reflection, thank you so much for that, Leanne. I felt compelled to say this other role that I think we as a board have, which is how to help support pacing. That start, stop, boomerang, backlash, the evolutionary nature, is it transformative or is it not? I think we owe it to you all to help that pacing question. Pat, you asked it, Leanne, you said it in a different way. I would like to end this retreat, with some deliverables or some accountability back for us as a board around, are we asking for this really wild 180-degree shift? Are we okay with 2-degree incremental adjustments over time, or everything in between? But I know we haven't landed on that for you, and I think that would be helpful. So thanks, Clarice, for the moment to say that before I forgot. I appreciate it.
Absolutely, absolutely. So thank you all for creating this container to begin to build a different kind of shared reality and analysis of what you need to do and where you need to go and how you're going to get there and how you're going to get there together, right? In a completely different way. Building on, though, not lost. Thank you. We're going to shift now to Jeremy. I think you're up to talk a little bit about Diana. Actually, you're going to introduce this, right?
Yes. Thank you, Clarice. Thanks so much. And really want to recognize the discussion that you all just had as sort of such an important foundation for the rest of the conversation today. Because really, as we move into the next few hours, it's about thinking, just as you all have been doing, what's the work looking forward? And so all of the conversation you've had, I think we hope really sets the foundation for the discussion of, and to Brenda's point, Leanne's point about, so and Ebony's like, what does that look like for the board? What does that look like for the board in the container that you all have to change the conversation, to have authentic discussion, and to take the action with the pacing that will move the work forward. So as you know, Jeremy's going to walk us through this, but at the 2021 retreat, the governor had asked the board to focus on the priorities of health equity, the waiver, the cost growth target, and focusing, and you all added sort of using the committees and focusing on your committee work. And so thinking about the proposed 2022 work and how of the board and how it connects with and supports the work of the agency. And so Jeremy's going to walk us through, I think, the roadmap. I think you saw it in January, but we'll share more about that. And then really what we want to ask all of you, so you'll hear from Jeremy, but it's very consistent with the conversation you all have been having, is, where is the health policy board's work? How does it align with and support OHA's work on health equity and anti-racism? And then we'll take that down. We'll hear from Jeremy, we'll have some discussion. And then after our break, we'll sort of take it down to some of those specific buckets of work. So Jeremy, I'm gonna hand it over to you.
Great, thanks, Diana. And as you all recall, we spent a pretty good chunk of time on this in January. So really just going to do a pretty quick overview and just a refresher to kind of bring your minds back to what we talked about in January, which is really that, as we've, I think, been working on a variety of priorities that could seemingly be seen as sort of in isolation. Really, we see them as being pretty connected towards a broad vision that we've been on as a state in terms of equity, access and coverage, and cost containment and quality. So want to be able to describe how we think those things fit together. Next slide. We've made, as we've talked about in the past, we've made significant progress. As you all know, we've really seen huge gains in terms of quality and outcomes with CCOs, especially where we've been incenting improvements through the quality pool. We've also made really significant gains in terms of coverage. It's hard to believe. Last week, I think, was the 12-year anniversary of the Affordable Care Act, and it's a little hard to believe that we were at a 15 to 17% uninsured rate before passage of the ACA. Today, and these slides are a little outdated. These are from our January time, but as we talked about with redeterminations conversation a couple months ago, we're now closer to a 96% coverage rate through the pandemic, and really made significant gains. Next slide. And as you all have been talking about yesterday and today, while we should, I think, stop and be proud of the work that we've done, we have so much more to do, especially as it relates to eliminating health inequities. We've seen really significant coverage inequities exist. We saw one of those for Black African American folks in the state drop pretty dramatically from 8% before the pandemic to about 5%. But we still see much larger rates of uninsurance for communities of color than for white folks in the state. We also know that costs are still a significant challenge. I don't think we quite yet have our arms around how this has shifted through the pandemic, but I suspect has only gotten worse as we've seen a lot of cost challenges within the healthcare system, and ultimately we see a lot of those costs get passed on to families and individuals through copays and deductibles that ultimately create pretty significant barriers to folks getting care. Next slide. So as you can go to the next one. As an agency, we've been implementing the 10-year goal around eliminating health inequities and the board's definition around health equity. We've kind of taken a step back and said, how do we really drive equity across the health system, and how do we really drive alignment? And that has sort of led us to think of a principle of there's a real opportunity to start to simplify and better align things, especially across different health insurance markets and different programs within OHA. We now have within OHA the not just 1.4 million people on the Oregon Health Plan, but about almost 500,000 folks who are getting coverage of some sort, in essence, the commercial market through public employee and marketplace plans. We're getting pretty close to providing coverage to nearly half of the state through a variety of different programs and a variety of different expectations. And so how do we really start to align things in a way that help us achieve this 10-year goal more quickly? Next slide. So we've sort of put those into a few buckets. One is continuing to drive towards getting to the point of universal coverage and ensuring that every individual in the state has access to high quality, affordable care. That's really coupled with needing to get arms around costs. As costs go up, it becomes hard to provide coverage. And also when folks are uninsured, that also drives high costs within the health system. So implementing the statewide cost growth target and getting our arms around total healthcare spending in the state, also a critical strategy. And then third, really pushing on the next wave of delivery system and market reform, starting with work that's happening underway within Medicaid, but then looking broader out and trying to align within other markets and looking to see if there's a way to potentially create a pilot where we really would start to think about the various healthcare markets as really one delivery system and not such huge differences depending on the type of insurance that you have through something that looks like a multi-payer value-based payment. Next slide. Next slide. So in terms of universal coverage, there's a few key strategies we think to be able to get from where we've been around 94-95% coverage today of closer to 96, and how do we really get to as close as we can to 100. There's no one thing that's going to fill that final gap, and it really comes down to a variety of things. One, as we go through the post-pandemic redeterminations process and potentially have up to 300,000 people come off the Oregon Health Plan, doing that in a real thoughtful way and trying to not lose coverage for folks or mitigate that as much as we possibly can. Second, continuing to build off of work that's happened within the Affordable Care Act, but fill in some pretty significant gaps that still exist. One of those was for folks who are ineligible because of documentation status, and Healthier Oregon, Cover All People will fill a really significant gap in that. Yesterday, the administration announced a rule change to fill a family glitch, which is another gap, and so excited to see potentially some more gaps at the national level be filled in as well. Next, I'm really trying to, go back one more. So next is really making sure that we then start to preserve coverage for folks once they're in. And as people are having income change or life changes happen, where they would normally be bouncing from one type of insurance to another, especially in and out of Medicaid, that we really try to reduce that churn. This session, the legislature passed a significant bill to create a new bridge program that would allow folks to stay within their CCOs up to 200% of federal poverty level, which could really be a significant reduction in that churn issue. And then a little bit later, farther out, looking at, okay, what are other marketplace reforms or reforms in other markets that continue to help us fill in gaps in coverage. Next slide. Oh, can we go to the next slide? Be stuck.
I'm going to go ahead and share my screen. I think Chloe is having some technical.
Okay, no problem. Next slide. In addition to coverage, this is will be the second year of the statewide cost growth target. On Friday, we're having the first, which will start to begin an annual hearing on cost growth and what's happening within costs within the state. While this is sort of a wonky thing, that it's critically important, I think, not just for getting healthcare costs under control, but for equity generally. As you know, we've set a target as a state of cost growth of 3.4% over the next 4 years. That compared with national projections of about 5.5%, the difference is about $16 billion over 5 years. And that's important not just for healthcare, but also for freeing up resources to address a variety of other social issues and investments that really impact equity. It's hard to put the dollars into education and housing and a variety of other areas that are critical when healthcare is sucking up so many of the resources. Next slide. Next slide. So then on delivery system reform, again, a couple steps we see in the process here. One, step one is our 1115 Medicaid waiver, which we've applied for in February, or now in negotiations with CMS, expecting to have that finalized by the end of the summer, and 4 key major components in there to advance equity. One, making it easier for people to maintain their Medicaid coverage once they're in, and be able to have Medicaid follow them through a variety of life events. Second, really trying to stabilize and minimize the disruptions in care as folks are transitioning from one system to the other, such as going between in and out of public safety or behavioral health systems, where traditionally Medicaid isn't allowed to follow folks. Third is continue to push on more flexible spending and really pushing the healthcare system to make more upstream investments and investments in prevention and primary care and other places that will really impact equity as well long term. And then finally, asking for some additional federal resources to really empower communities to drive investments in places specifically that will correct historical health inequities and improve equity. I would say that in addition to this, in the 1115 is also the bill that came out from the session around redeterminations and creating a bridge plan, and expect that that will likely lead to an application, a different type of application rather than 1115, but a second waiver that will also help with the goal here around maximizing OHP coverage. Next slide. Beyond that, then I think the task becomes, how do we really start to bring PEB OEB and the marketplace along, and how do we have really consistent expectations of the delivery system? We have largely the same providers in each of these markets that are providing care, but we have very different expectations of what we expect within Medicaid versus PEB and OEB in the marketplace. Just one specific example of that, in CCO 2.0, we have CCOs doing health equity plans, and we have them doing community health improvement plans. The commercial carriers, who largely are the same players that are providing services of Medicaid, aren't required to do that. So we sort of have our lowest payer, Medicaid, who pays the least, with sort of the highest expectations of the delivery system, and needing to really start to align that. Next slide. We see the alignment in a couple of really key areas. One is around consistency around our expectations of total cost of care and value-based payment. Additionally, around more alignment around accountability and paying for outcomes, and having consistent expectations and accountability around equity, around quality and outcomes. And then third is around community voice. The CCO model is really embedded in community, and trying to really have a strong community voice. There's no similar analog within the commercial market, despite the fact that it's a lot of the same players. Next slide. Why don't we go? Oh, so then I guess finally, we've also been working on a bill that passed in 2019 to think about one way to possibly do this alignment would be to try to create a pilot in a community where you have a contract with providers that really looks like a consistent contract across all of these markets, and really thinking about aligning the reimbursement methodology, aligning metrics in a consistent way across Medicaid, federal marketplace, and potentially Medicare. We're due to give a report back to the legislature later this year for them to consider in 2023 on creating a potential pilot. And the idea of really here is to say, if you're talking about a lot of the same players in a community, can we really think about that as a local delivery system instead of a local Medicaid system and a local marketplace system and a local Medicare system, and think about trying to bring those together in a community. Next slide. So our overall timeline, pretty aggressive. We've got a lot going on over the next couple of years. As I mentioned, planning to have the 1115 waiver approved by late summer. Following that, we would expect, and this timeline hasn't quite been updated to fully account for what came out of this last session, but it would expect that following that is a waiver application later this year around the bridge plan, which starts to get into the beginning of more marketplace reforms. Expect that to probably be 1331 or 1332 waiver. And then in 2023, the legislature will consider the multi-payer plan. Have had some initial conversations with our federal partners around that as well, and they're very interested to see what we come up with, and are thinking about similar types of pilots at the federal level. So with that, I think we'll open it up for questions or dialogue.
So I have a question. I'm sorry, I'm cutting both. I'll raise my hand. Sorry.
Let's go. Thanks, Ebony. Let's go Sandy, Ebony, then John.
Thank you, Jeremy. So where do I, sorry, your multi-payer value-based budget, when you've got Medicaid, you've got the state plan, you've got marketplace and Medicare, and aligning reimbursement and metrics for those, is it going to be a universal metrics for all of those groups? Because, if I'm paying, into my state plan and competing with Medicare or the marketplace exchange for fair value, is that going to occur? And then number two, I guess your concept paper, where can I find some of this information? I guess I wasn't at the January meeting, so those are a couple of questions I have.
Yeah, thanks, Sandy. I'm happy to send you a little bit more information. The concept paper, as I mentioned, this timeline is a little outdated. We haven't gotten around to finalizing that. Omicron sort of threw another wrench in things this beginning of this year, but are working on trying to get that finalized and out so folks can start to respond to it. And this is really being done in partnership with Representative Dexter. This was thing that she really championed this last legislative session, and are working closely with her. So expect to have something this summer that folks can really start to respond to. In terms of the reimbursement rate and metrics, and as I mentioned, this is really a 2023 legislative conversation. I think we see those as two major barriers to driving alignment and to driving work that could advance equity more quickly. And they're both things that I think for 10 years we've really struggled to figure out how do we make movement on. So I think in terms of payment, we aren't necessarily talking about aligning all of the payment rates to be the same, but are thinking about, as we're making this big shift from fee for service to value-based payment, is there an opportunity to do that in a consistent way and say, just, as an example, say a provider in a particular community of the state, rather than having them come up with one value-based payment for Medicaid and a separate one for PEB and OEB and a separate one for Marketplace, is there a way to have the same type of payment arrangement, maybe not the same rates, but the same type of payment arrangement across those, that makes it easier for providers and frankly makes it easier to really have that payment be tied to equity and advancing equity. And that's really coupled with, it all comes down to metrics. When we're talking about value-based payment, those payment rates are largely based off of outcomes. And so I will say, I don't think we've solved this yet, but the vision is, where's a sweet spot, recognizing you do have differences in populations in different markets, but is there a sweet spot in there where you can come up with a payment arrangement that's more consistent across markets and has some consistency of quality outcomes?
So just one quick question, then what state were you looking at for value-based payment structure?
Well, we've been looking at a number of states. Massachusetts and Rhode Island are still are sort of way out there. But I don't think any state has really solved this. I mean, when I say way out there, they're like, way out there compared to the rest of the country. But I think still also pretty nascent phases of trying to figure this out.
Thanks, Jeremy. Ebony.
Yeah, I just wanted to know, are you able to share or talk about some of the details of kind of the negotiations, or, essentially, are there things that in our proposal we're having to kind of provide additional information or make a case on? Can you talk a little bit about that? Or?
Yeah, absolutely. So we're now in a spot where I think we're probably 3 weeks into a more weekly cadence of conversations with CMS. The way it generally works is, they have our application, they had some initial sets of questions, they need to make sure it was complete. And then the next phase, which we're now at the kind of front end of, was mapping out topics for weekly discussions out over the course of the next couple of months. So that we're basically going through kind of major ask by major ask within the waiver and answering questions for them and getting some initial feedback. We aren't quite to the spot yet of things being go, no go. I expect that will be kind of the next phase, and the next month or two, we'll start to get more feedback from CMS that will start to kind of force us to say, okay, we're seeing that they've got a lot of hesitancy around this one, and how hard can we really push, or they may just tell us flat no on some things. So we aren't quite there yet, but are basically going week by week on each of the asks and really trying to help answer questions so they can understand what we're trying to do.
Thanks, Ebony. Thanks, Jeremy. John, please.
Yeah. Well, Jeremy, I guess to be direct, I still haven't succeeded getting 2 years of work on universal health plan on your roadmap. We're talking about the same things. I mean, board members, we're talking about $50 billion of power every year. 50 billion. Oregon Health Authority is already involved, as you've just heard, in Medicaid, commercial, and Medicare. They already have hundreds of thousands of lives in each of those. And Jeremy's terms, alignment, one delivery system. We're trying to work it towards one payment system. But his challenge is he's trying to do that by convincing multiple payers to do the same thing. multiple payers. You know, I mean, at the risk of the analogy I brought up yesterday, he's trying to make an old car keep running and keep running better and ignoring the electric car that may be out there. And Jeremy, the work of the task force deserves to be on your roadmap. We got to talk about it. You know, I guess it's not quite as bad as racist, but sometimes it amazes me the feelings that come up when the term single payer is used. We shouldn't be afraid of that. And we should be sophisticated enough to understand that we're headed in the same direction. And, you know, we should have that conversation. My hope is to have it here at the Oregon Health Policy Board. Maybe it should be other places. I think it's going to be at the legislature. I think from an equity point of view, ultimately, those billions of dollars have got to be focused so that there's no difference in what the delivery system is paid for a person who's in Medicaid versus a person who is in, quote, commercial. So I'm going to spend my 36 hours on the Oregon Health Policy Board in the next year trying to get that on the agenda.
Thanks, John. And I'll actually just own responsibility for these slides being outdated and not putting in. There wasn't an intentional exclusion, and we talked about that in January. I should remember to make sure we included in there. I do think it's a critical component on how we have multiple conversations that are all sort of pointing in a common direction of how do we get to universal coverage? How do we get to a more consistent delivery system? And I think the 770 task force is a critical piece of that. So that I will make sure that the next presentation, we definitely tie that in.
Thanks, Jeremy. Other questions or comments or reflections on what you've heard from Jeremy as we move towards our break? But want to be sure there's some time here for any additional board comments or questions. Okay, so what we're hoping, right, is that as we move, we're going to take a 10-minute break, but as we move into the afternoon, that you're thinking about yesterday morning's conversations with the committee, that you're thinking about the discussions we had in the afternoon, that you're keeping in mind the discussion and the presentation from Pat and Leanne, and then folding into this what Jeremy's just shared. And so as we shift into when we come back in about 10 minutes, we'll be talking about the committee work. We'll be talking about cost of care. We'll be talking about health coverage. And again, health equity being pulled through all of those, and the discussions we've had being pulled through all of those. And in each one of those conversations, we'll hear a short presentation from staff, some thoughts, and then really want to be hearing from all of you about the work, your thoughts on the work, and how we lift up the conversations we've been having thus far. So it is 9:48. How about we come back just at 10, so a 12-minute break. But we'll come back at 10, do what you need to do. We will see you all at 10 o'clock. Thank you so much. It is just 10 o'clock. Board members, as you come back on, if you could turn your camera on so we can see that you're back with us, that would be fantastic. Thank you. Give folks just another couple minutes to come back. Hello, hello. Welcome back, folks. Okay, I think folks will join us. Board members, just a request as you come back on, if you can turn on your cameras. As I shared, the next couple of hours for us is to really focus in on some specific buckets of work, and we're going to start with the committee work. And Steph Jerem is going to walk us through, I think, a couple of slides. And as you're listening to Steph, what we hope you'll be thinking about is, what are you seeing, but what did you hear yesterday? And specifically around anti-racism and equity efforts that should inform the board's work. And thinking about how, these are the questions we have for you. How can the board support committees to make sure that everyone's sort of working towards that goal to eliminate health inequities? And are there any structural pieces to sort of institutionalize that alignment and focus? And so want to be thinking about those pieces as we start the conversation. So Steph, I will turn it over to you.
Great, thank you, Diana. And I think my slides will be coming up. Perfect. Thank you, Chloe. My name is Steph Jerem. I'm the director of the Office of Health Policy within our Health Policy and Analytics Division at OHA. And I am here to share a roll-up of the committee work that is going on and kind of let you know where we're going in the future, what the proposals are. So if we go to the next slide, I'm going to just give a little bit of background and context. I know we have people coming in at all different stages of experience with the committees. I'll do a very quick recap on the priorities, which Jeremy just touched on, as well as our liaisons. We'll go a little bit more in depth on the focus for 2022 within the committees as they've currently proposed it, and then share some requests for you all and have some discussion about what that looks like. So next slide, just a brief background and context. So right now we have 11 committees. It's the most subcommittees we've ever had of the Health Policy Board. It's over 250 people. So that's how I like to think about it and contextualize the number of people in the state who are working on behalf of the board. It's a really significantly large body of work and a lot of time. The board's role in all of this is to really inform and to support and sometimes direct the work of the different committees. And so the slides today are really meant to help ground you in that work that they are currently doing, as well as requests that they have for the board. And as I said, we'll end with some discussions. So next slide, a quick recap. You can go to the next slide again. This is just to share if anybody's just tuning in. Again, these are the board priorities. Jeremy just went through those. 3 of them came from Governor Brown in January of 2021 last year. So that is the work centering on health equity. It is the work ensuring successful implementation of the cost growth program, as well as assisting OHA throughout the 1115 Medicaid waiver renewal. And then in the retreat in February of 2021, the board members all came together and said, we also have all this other work happening. We really want to lift up the work and support the work of the committees and ensure strong connection there. Next slide. Oh, did I miss a slide? Maybe, that's okay. So the way that we have done this is in various ways. But one of the strengths that we have are liaisons. And so this is board members serving, attending the meetings of the subcommittees, partnering with staff to plan for some of those meetings, partnering with the chairs and other people within the committees to really set the stage for the future of the work. We currently have David Bangsberg as a liaison to both the Public Health Advisory Board and the Health Equity Committee. We know that David will be rolling off soon, so it's something for everybody to be keeping in mind how we continue to support those committees. We have Kirsten, who is supporting metrics and scoring and the health plan quality metrics committees. Brenda has been supporting the healthcare workforce committee. We have John Santa, who's been supporting the Medicaid advisory committee and the health IT oversight council. And then Bill Kramer has been supporting cost growth target, and Ebony has jumped in to help with our behavioral health committee, which is one of our newer committees. And then we do have a couple of vacancies in the primary care payment reform collaborative work and the health insurance marketplace advisory committee. Just for awareness of who's supporting what and where we're seeing connections, those are board members that are more closely connected to this work. So next slide, thinking about the future of the committees, there are a couple of ways that we'll continue to get updates on this work more generally. So we have those liaisons that I just spoke to. Those people we build into the board meetings throughout the future, quarterly updates for the liaisons to speak to the work. We also have a digest that comes out every quarter that really informs the board about the work that's happening. And so that gives the high level sense of what has happened during the interim, what's upcoming for the committees, what's front of mind, anything that's due, all of that. So those are just for awareness of the ways in which we are connected to the committees. I'm going to dive in now. It's going to be a lot of words on these slides, but I'm going to actually walk us through it. So if you go to the next slide, we wanted to talk through the focus for 2022. So the committees themselves put this forward to you all to share a really high level. We said, give us one sentence, what you're doing in 2022. The liaisons will be able to speak more to any of this in discussion, I believe, if needed or if useful. But I will run through this just to really ground us. I think it's so important. We've talked about this over and over. We've heard from all of you that it's hard to get a sense of all the work that's being done. So I will take the 4 minutes that will take to go through these committee by committee. So the Behavioral Health Committee in this upcoming year is really focused on developing concepts to inform their definitive behavioral health metrics. And there will be additional work in order to develop those metrics, things like policy proposals or more information around their data and data infrastructure. How do we advance some of that work? So they're developing a lot of that. I know we have a lot of people informed on that work on this board. The Healthcare Workforce Committee is managing right now a nursing workforce staffing shortage study. They're also updating the healthcare provider incentive program evaluation this year, and we'll be presenting some proposed statewide health professional shortage area plans. So that's HPSA, if you've ever heard those words, as well as a new Oregon specific methodology for directing workforce development funds. And this is work that comes directly under the board to direct those funds and to help support that. The HEC, which is the Health Equity Committee, will be updating its charter and bylaws, reflecting the impact of COVID-19 on the healthcare delivery system. That will also include some reflection on the 2030 strategic goal. With that comes development of a new work plan and continuing to guide some of the work in the 1115 waiver application. HIMAC, which is the Health Insurance Marketplace Advisory Committee, they are in development with their work for 2022 as we speak. HITAC, which is the Health IT Oversight Council, is working on community information exchange and a state strategic plan for health IT. They update that regularly. Health Plan Quality Metrics Committee We had some robust conversations about this yesterday, but they are going to be working on updates to the measure menu. And this includes some new aspects around social determinants of health, the DQA sealants, an annual report to the legislature, evaluation of the meaningful language access measure, which was new, as well as developing a health equity quality metrics committee lessons learned report, as we're in the twilight of what Health Plan Quality Metrics Committee is, transitioning into the Health Equity Quality Metrics Committee. And so they're really trying to share some of their lessons learned. Next slide. These are our last four. The MAC, which is our Medicaid Advisory Council, they are working on a consumer experience recommendations report. They have a new community experience subcommittee of that group that's been really valuable in learning and hearing directly from Medicaid consumers. They're providing some of that information to help inform the 1115 waiver implementation planning, as well as the bridge program that Jeremy just spoke to. Metrics and Scoring Committee is going to be beginning the groundwork for changes to the incentive program structure overall, looking really closely at the healthcare quality measures by our REAL-D, which is the race, ethnicity, language, and disability, and SOGI, which is sexual orientation and gender identity categories as they're available. Looking at lots of other opportunities to consider equity. How do we pay for equity? And then how do we successfully establish that Health Equity Quality Metrics Committee that we spoke to? PCPRC, that is our Primary Care Payment Reform Collaborative. They are working on developing a primary care value-based payment model to be integrated into the work group strategies. This will help with identifying some opportunities for alignment across payers, so thinking more broadly than Medicaid. And then FAB, which is our Public Health Advisory Board, they are applying the health and racial equity capacity building learnings to the focus for the next year. So that came out of COVID in the last year, the grants that Leanne spoke to this morning. They will also be updating the public health accountability metrics, updating the public health modernization funding formula, and sharing their biannual report to the Legislative Fiscal Office. And I didn't speak to the Cost Growth Target Advisory Committee because you're going to hear from Sarah shortly. So that is the bulk of it. It's a lot. It's significant work. It's really monumental when we think about the overall work of the board. And so if we go to the next slide, I'm going to share when we ask the committees, we say, what do you need from board and from the board members? Go to the next slide, please. This is what they have been looking at, and they're thinking about the different roles that we've talked about in terms of the roles that the board can play. I think you can glance through this one. I'm not going to go line by line in this, but you'll see that there is different needs that the committees have for you that they've set up, whether it's leading some of these efforts around communication or hosting public hearings, which you'll hear about. There's needs for collaboration. How are we doing our work? What does a work plan look like together? We want to make sure that the board is actually informing this work going forward. And then in some of it, it's really big, significant work that the committee has done that they're asking for some support from the board in the announcement of that, the dissemination of that. So given all that, if you go to the next slide, oh, and here's even more, sorry, I had 2 slides on that. So you'll see, we can go back, Chloe, one. Thank you. I just want to pause so you can look at this as well. So again, lots of collaboration, lots of support, sometimes communicating. We started with some of the leadership on the slide previously. Lots of different roles for the board to be playing in this work. And I think you can think collectively of the board as the board, and then also the individual liaisons probably play different roles as well. So to my final slide, thank you. I think we have some additional considerations and questions, and I know Diana and Clarice will walk us through a discussion, but I did want to leave you with some questions and considerations here. So thinking about how we have so many committees right now, Not all of them have liaisons, and that's a lot of additional work for board members. Are there other strategies that we could be utilizing to build awareness and relationships? I think a question about how the board can support those committee collaborations we spoke to yesterday. We've had some success with those so far, but we know that there's real opportunity in pulling committees together to work on things collectively. And then wanting to make sure that we leave space if the board has any requests of the committees. From your perspective, what are you hoping to see? What do you need from your committees? Those types of things. So with that, that was a lot of information. Thank you for being patient, and I will turn it over to Diana and Clarice.
Thank you so much, Steph. And just as there's a lot of information, there's so many questions that we could be talking about and addressing, and ranging from, and we can sort of touch on some of these, but the question about when committees don't have liaisons, and the questions that we really wanted you all to reflect on, and we'll sort of see where the discussion goes, but thinking about, given what you heard yesterday, and what did you hear yesterday specifically about anti-racism and equity efforts that should inform your work with the committees? And this goes to some of Steph's questions too. How does the board support the committees to make sure they're all working towards eliminating health inequities? And are there, for example, are there some structural pieces that the board should put in place to institutionalize some alignment, or around the goal to eliminate health inequities? So those were some of the questions we wanted to throw out. So what we want to do is invite your reflections, because this conversation informs the work of the board vis-a-vis the committees, but also obviously the work of the committees. So what are your thoughts about maybe things that you heard yesterday that should inform how the board works with its committees and supports its committees? Brenda, please get us started. Thank you.
Sure, you bet. Thanks, Steph, for that presentation. That's always really helpful to have both the overview and then see a little bit deeper into the specific outlines that the committees are contemplating. So I've got some feedback and then some suggestions, Diana, to your question. I think what would help me understand how the committee's work really ties to the board's vision or the agency's vision is to have a little bit more description to each one of those committee goals. How does it specifically help us eliminate health inequities by 2030? Like, what is the direct explicit link between one goal and the elimination? Some of what you listed, it was really obvious to me. I could see that link pretty easily, but others not so visible. So that's a request. And then, again, just that for the committees to help us understand, how can we be really explicit about the obstacles that are in the way? I love the earlier conversation, and both based on what we heard from committee leadership yesterday around, what they need from us is a little bit more guidance or this kind of co-creative space. So I would love to understand that next layer on the iceberg. I love using this analogy throughout our time together, but if I'm not talking about the mental model, I'm talking about that layer right above it, where the committees could tell us, these are the named explicit obstacles in achieving our health equity goals from the committee landscape that is either in policy or it's in procedural framework. And I'd love to understand that so that we as a board can have better, or certainly as a liaison, I might have better visibility into the committee that I'm supporting at how do we change the conversation within that specific obstacle named. So that would be really helpful. I think then a couple other thoughts just based on our conversations from yesterday. I love the idea about perhaps creating a more explicit onboarding and inclusion kind of training and framework for committee leadership. I think about the dyad between what we heard in the, from Ignatius and Susan and from Leanne about the composition of the committee and how much mobility is actually in each one of those functions. So how do we really direct the notion of onboarding and engagement and inclusion practices within the committee structure itself. To do so, in my mind, requires some additional support for our leaders to understand how does this complex system work, you know, at its, like I've been on this board for 4 years and I'm still learning so very much about how the pieces kind of fit. And so for any new chair, I think it's probably really challenging to understand how to not just navigate the conversation, but understand the overlaps or the places where these intersections really matter. So I'd request for some specific efforts around onboarding, health equity, education, training and support, and some specific, you know, kind of goal alignment connection points. We started it. I think there's some really great opportunity to create synergies across the committees. So I'll leave my feedback at that for now.
That's really helpful, Brenda, in thinking about, right, some of the things that tie the committees together, some of the information that would be really helpful for the board to have as you seek to do that and sort of hold it all in the container to moving towards eliminating health inequities. John.
Yeah, I have two examples that I think I'll throw out there. The first is the board is going to hear the MAC, the Medicaid Advisory Committee report on member experiences in May. Now, I think that some of that will transport to other committees, but I think it could also transport to DHS. And you know what I think, wouldn't that be interesting to see if DHS, who has members, by the way, on MAC, if DHS and MAC could work together, because I think when you see their findings, you're gonna wonder what's going on in terms of equity, and then how are people being treated. So that's one. Then on my other committee, which I'm more challenged by, because you know I'm not a very technically savvy person, as you all probably have seen. But at High Talk, you know, they're working on a community information exchange, an exchange that will link delivery system with social service folks. Now we're fortunate on High Talk to actually have a former member of the Health Equity Committee who's joined High Talk and is involved in that. But I think in that process, which you know is just starting, there may be some other committees that are interested in that because it could have an impact on them. So I just throw out those two examples.
Thank you, John. Kirsten.
Thanks. I just wanted to echo, or I appreciate the earlier comments, especially about being explicit about kind of how the committee work is. Like, we get regular reports from committees, but maybe included in those reports should be the regular questions of how is this work linked to achieving our health equity goals, and what in your mandated work plate is taken away from that, or and what are other obstacles that are interfering with achieving that work, making it hard to do or hard to achieve. And I think those can be two different things. Because I felt like yesterday we also heard that some committees had long lists of mandated work that was impacting their capacity to focus on other goals. So I think we need to raise that up. And I was excited to see on the earlier slides that, like, the Public Health Advisory Board, it looked like there was going to be a conversation at OHPB with that committee around policy ideas and wrestling with some things together, which I think is very good to think about how we have a transition, not just reports, but how do we have creative conversations and ideas coming up from the committees that then lead to legislative change or other change that is important. And on a small note, I have found our Tuesday 8 a.m. educational webinars to be helpful uses of time to dig into unique topic areas at a level that even sometimes that feels too short, but certainly like we weren't able to process within our regular board meetings. And I just, and we've often invited, some of those have been led by committees, some of those have been joined by committees. And I think let's keep that up in terms of sharing that invitation. Those are not just for the board. And to that end, usually it's like, now do board members have any questions or want to have a conversation about this? Maybe we shouldn't restrict it to the board. Maybe depending on the topic, like, that could be an opportunity for committees to participate and bring those voices, those sometimes more knowledgeable voices forward as well.
Thank you, Kirsten. And in that sort of the tie back to what Brenda was saying too about how if the committees are bringing policy ideas, where on the systems triangle, right? Can you make those changes? And so if the board is using that as a lens to say, how can we support this committee to make that kind of change to really get deeper under the iceberg? Oscar.
Yeah, so I'm really sort of kind of thinking about what we heard from Director Allen and Director Johnson about the importance of continuity, the importance of keeping this work moving forward, particularly during a time of transition. I think this is the first time in the last 6 or 7 years that I've been on the board that we've actually had 9 board members. And, unfortunately, we're going to have David transition after May. So for me, we just don't have a large enough board to meet the need of this work. We have 11 committees that report to the board, 9 board members. We're constantly sort of at least 1 board member short, maybe sometimes as many as 2. We need to prepare for potential other transitions on the board as well. So to me, there's a need to grow the board for at least 2 board members, so that each committee, we can actually designate a board liaison. I think that the committees are important enough to deserve a board liaison. So that's just kind of like my comment.
Thank you, Oscar. David, you had your hand up.
I mentioned it the last session, but I just want to sort of be a bit more specific in terms of my recommendation. I agree with Oscar. There's a lot of work to do with committees. The committees are potentially underutilized, and the communication, it takes a lot of time and energy to make sure the communication goes in 2 directions, from board to committee and committee to board. And we really need to reinforce that and pay attention to that. I think the session we had yesterday morning was really helpful to understand what the committees, who's on the committees, what's doing what. More of that would be helpful. But I think in terms of achieving health equity, to be more specific on my earlier comment, I think the HEC and the Public Health Advisory Board would welcome a charge by this committee to say, give us the 4 most important goals to achieve health equity by 2030. What are those? Let's start to develop a work plan. And I think there's enthusiasm, interest, expertise, and a hungriness for direction, or hungriness for giving to supporting that work and saying, please go forward and partner with us to develop more granularity about what our next steps are.
Thanks, David. I have Bill, then Sandy, then Brenda.
Thanks. Very quickly, just wanted to strongly agree with Oscar's point about the desirability of expanding the board. I feel bad about the 2 committees that don't have a board liaison. I'm interested in them myself, but I think I could contribute, but I feel stretched pretty thin already, and I'm sure other board members do as well. So I think the right solution is to have a larger board so we could effectively engage and collaborate with those committees.
Thank you, Bill. Jeremy or Steph, what's in the legislation? Can there be more board members, or is it limited by the originating legislation?
I'm pretty sure it's a pretty hard limit in statute.
That would have to be a statutory change, but it could be something the board recommended. Thank you. Sandy.
Thank you. So I guess I just want to get caught up, House Bill 4035 and the options of, creating a coverage that allows for continuity for people getting disenrolled. Are we making, you're bringing up a report back to the Legislative Assembly in May. I guess maybe I'm missing something, but where is all the information on how you're going? We've seen some of it, but to make sure that, I saw some information, Jeremy, that you shared that, let's make sure that there's that word out there. How do we get X amount of people to transition from one insurance to another and not be disenrolled? That's a really hard and critical point that it's not, you're not going to make everybody happy because it's not, I just don't think that we're prepared to get some of this completed within that time frame. This is a February legislative update, and they pretty much gave you the authority, or the Oregon Health Board authority, or the Oregon Health Authority to get this completed. So I guess I find this very critical in making sure that we don't lose people down the road, because right now, I understand achieving health equity by 2030, but we need to achieve a continuity of care by, right now. It's not, I find that more of a priority for Oregonians than, listening. It's important, but we need to define the importance of each of things that have been identified to get done in a time frame. So I'm about, let's get it done. And I don't know if that's going to happen. So, and make people happy.
Go ahead, Jeremy.
Yeah, thanks, Sandy. I think we all share your concerns very much as well. I think there's two distinct parallel bodies of work that are connected, but on slightly different timelines, but need to be really well connected. And one is the outreach and enrollment assistance that needs to happen through the redeterminations process, independent of the bridge plan and what that ends up looking like and getting federal approval. And the legislation calls for initial report back to the legislature by the end of May. And for us to do that work with community partners. So we're in the process of getting that stood up, and the team really wants to try to not duplicate efforts and try to pull in community partners and others that have been helping us with outreach along the line. So that does have a pretty fast track of a report back to in May, but then the work will be ongoing throughout the next year. The bridge plan will be on a parallel track. The goal is to have that bridge plan up by the end of the fully up by the end of the redeterminations process, so that we're sort of holding people who will be enrolled in it. But that's going to take a bit more time to work through a task force that the governor appoints that will have recommendations in September and an application in the fall to the feds, hopeful for approval in the spring, and then implementing it thereafter. So those have to be happening at the same time. But we did get some additional resources from the legislature around outreach and enrollment. And I think our next step is now beginning to engage with community partners on how best do we use those resources.
And really appreciate that, Jeremy. And we do have some time later in the agenda to focus a little bit more on coverage. So thank you, Sandy, for raising that, and know that we're also going to be coming back to that in a bit. Brenda.
Thanks. My follow-up is in response, David, to your feedback about whether or not it's the board's responsibility to give explicit direction to the committees, or how we do kind of co-creative planning. And it occurs to me that, and I think an effective strategy may be to really resource the facilitation of those conversations. So it's not, inappropriate use of power and that rank, from the board to the committee, thou shalt, but it's like how we, and I don't think that's what you were saying, but I think how do we kind of weave together the committee's intention, especially when we think about community and demographic representation that's shifting on each of the committees? How do we engage those voices to think about what do you want to do? How does that feel in alignment with where the board's at? And perhaps we don't yet have enough facilitated support for those very conversations that feel like it's an ebb and flow instead of a up or down. Yeah, thanks for that.
Excellent point, Brenda. Thank you.
Oscar.
Yeah, I kind of want to maybe tie this back to what Brenda just talked about, but I noticed that the Health Equity Committee is revisiting their charter, which I think is probably actually a good practice for all the committees to do. I don't know how, I'm glad that they're revisiting. They're like, we just had a pandemic, things have changed, are all the other committees who have been established like for a longer time than the Health Equity Committee, looking at their charters, revising their charters, updating their charters so it connects back to like the present time and the 2030 goal might be something for us to consider. And I also want to go back to this, like, oh, well, it's mandated that we can only have 9 board members, right? We've talked about like, let's identify those barriers and let's remove those barriers. So I want to make sure that, great, we've identified a barrier here. It's, we can only have up to 9 board members. So now let's change that. Let's move forward to like change that. Let's, I saw about the composition of the board. How about we also add a consumer voice has to be part of the board, elements like that.
Thanks, Oscar. I saw a lot of nodding heads. And so that may be a specific piece of work for the board in terms of thinking about what legislative, what changes might you propose to the legislation that originated the board. As we wrap up this piece and know that a number of things have been called out here around thinking about areas of alignment across committees, thinking about how the board can support committees, but what support the board needs in order to support the committees. And then Oscar's call out about, and this has been a theme throughout our conversation today, as well as yesterday, but Leanne and Pat also sort of called out, identifying those barriers and figuring out ways to remove them, not just calling out the problem, but saying, so what are the things that we need to do to get some of those obstacles out of the way so that the board and the agency can do the work to get to the goals of eliminating health inequities. Any other reflections on the committee work before we shift to sort of your next bucket of work around cost of care? Any further reflections? And I know that Tara and Steph and others are sort of taking notes, and I think the idea is then to come back to you and say, this is what we heard, some of the things you want to do. And here's what that might look like in 2022 for the rest of the year. Clarice, oh, go ahead, Ebony.
And I just think, this is very linear, what I'm going to say, but I think that from just also a technical point, because I joined the board in the pandemic and everything was like so fast moving, I find myself always wanting to make sure that I'm clear and I'm not missing or overlooking anything when it comes to kind of our statutory responsibilities as we do the work. And, I think, I feel like I bring this up maybe every so often, but, like recalibrating, that's just a piece that, I also just have in the back of my mind to help make sure that then I'm, that we are not missing the mark in any areas of kind of just what we're called to do. So
that makes a lot of sense, Ebony. So it sounds to me, at least from a number of you, taking a look at that statute again and what's in there and what you all might recommend should be changed, but also to remind yourselves of what's actually in there in terms of your responsibilities. Clarice, did you have a wrap up as we move to the next piece?
I believe that Tara also put in the chat a link for the statute. And just wanted to put a little post-it. We understand that there's conversation about succession planning and that work to also be done. Sounds like it's coming up in your May meeting. It feels like these are conversations that fit with that. You know, what taking stock of now and what you need now going forward.
Thanks, Clarice. Ebony, did you still have your hand up or? Okay, great, thank you. All right, so a number of pieces here that I think will come back to you in terms of what some of the work related to committees. And obviously, as we shared, there's a lot of information here, a lot of questions. It's a lot of work and sort of finding the way that the board can think about it holistically and what are the pieces of alignment and how does it all continue, how does all the work continue to drive in the same direction, even when it is in some ways lots of different tentacles and pieces of the work, but that doesn't mean it can't all be driving. And Brenda's suggestion about really getting explicit about how are each of these committees driving towards the 2030 goal. So we want to shift to another piece of work that you all have around cost of care. And I know Sarah Bartleman is going to be joining us to do a presentation on this. And as you all think about this work, I think the questions here are around how does the implementation of this work move towards health equity? And what are some of the issues that you want to continue, the board wants to continue to address and to see addressed? And what are some of those opportunities? So Sarah, I'll turn it over to you to lay the groundwork and then we will have board discussion.
Thanks, Diana. Hi, everyone. Good morning. I am going to present just a little bit of a summary with a little bit more detail than I think Tara and staff have presented over the last day and a bit in terms of some of the work that we have accomplished on the cost growth target program implementation, as well as what we see are some of the key milestones and touch points with the board in 2022. I want to second everything I think that was just said, that I think there have been a number of things in the discussion that you just had that are not about to be reflected in my slides. And I think we can take that back and incorporate that and continue to think about where we strengthen those connections and make some of those commitments more explicit. So recognizing up front that I'm going to fall short on that front, but I heard your last conversation. Next slide, please. So just to recap, cost growth target program implementation is one of the 4 board priority areas. A couple of highlights and accomplishments from 2021. The implementation committee completed and submitted its recommendations report to the legislature. That really guides all of our program operationalizing and ongoing implementation. We had our accountability bill passed. That was House Bill 2081. That gave us the authority to have accountability mechanisms, performance improvement plans, and ultimately financial penalties for payer and provider organizations that continue to exceed the cost growth target without good reason. We stood up our technical advisory group. That is a group with all of our payers or the data submitters for this program. And that group has been meeting monthly, working through a lot of the technical challenges and really operationalizing the data. We implemented rules for data submission, and our payers completed a huge lift and submitted the first data file for this program. So we've collected data for 2018, 19, and 20, and we are finishing up validation of that file. I think we are more than 90% complete with the data validation and looking forward to beginning some reporting out of that data later this year. So a lot of big accomplishments in 2021. Next. So for 2022, there is a lot of work. A lot of it is pretty far in the weeds, but we really wanted to lift out 4 potential milestones for the board consideration and board engagement. So let me just cover them real quick, and then we'll go more in depth in the next slides on each of these. So first, we have hosting and holding the initial cost growth target public hearing, which, as Jeremy and others have mentioned, is going to be on Friday, and I hope you can all attend. We have standing up the new cost growth target advisory committee. This is our successor committee that replaces the original implementation committee. We want to engage the board and have the board inform the development of those accountability processes. So we have the legislation in place now, we have the authority to do that, but we need to actually build that out. What does it mean to put an entity on a performance improvement plan? What is a meaningful financial penalty? How does that fit into the broader ecosystem of all of the transformation efforts? So we want to have some conversations there. And then throughout the year on an ongoing basis, we are going to be producing reports and data on a number of topics, focusing on cost growth impacts, cost growth drivers. And we really see a role for the board in continuing to understand that data, discussing it, and thinking about where are some additional policy opportunities. So that could be big P policy, it could be small p policy, it could be connections with other bodies of work that are under the board or with other committees. Tara shared yesterday that cost growth target, health equity committee, health plan quality metrics committee, workforce. There are a number of places where we've already been coordinating across committee, and we think some of that can continue, especially when it comes to this identifying additional opportunities. So those are the big bodies of work. Let me pause for a second. Before I go into the details, Jeremy or Bill as our liaison, is there anything else that you'd like to add? Not hearing anything. Well, let's go to the next slide. All right, so for our first milestone, the initial public hearing, as we've said, that is on Friday. This is our initial public hearing, and for this meeting, we're really focusing on the impact of healthcare costs on people in Oregon. Future cost growth target public hearings will be more focused on performance relative to the cost growth target, on what those cost drivers are, on what accountability mechanisms might be put into place. But this initial one, we're really focusing on the impact that high cost of healthcare has and why this is important. Why do we have this program? Why is the board focusing on cost growth, cost containment as a priority? I think this is a really great place to bring in some of those connections to the equity work, opportunities for improvement. And we're looking forward to really grounding the rest of the implementation work this year in the hearing on Friday. In terms of the board role, I've been working with a number of you who have volunteered as moderators for the hearing. Thank you so much for that. This hearing is being convened on behalf of the board. So really seeing the board in a leadership role here. So hosting the hearing, moderating the panels, and then ongoing. I think in May, we're hoping to hold some time with you to reflect on the findings and everything that we hear on Friday, and figure out how that informs our work moving forward, whether that's future hearings, changes to the program, additional connections to our equity work, and more. Next. Our second milestone is appointing the Cost Growth Target Advisory Committee. I've been talking to you over your regular monthly meetings about this work, and we are going to be coming back to you at your regular May meeting with a proposed membership slate. Last month, you reviewed and approved that ideal composition matrix, and I think that really is giving us a tangible model for understanding what we mean when we say we want a representative committee, thinking about representation across a number of different dimensions. So really hoping to get that landed in May and kick that committee off in May or June. So we also see the board role not just in approving and appointing that advisory committee, but continuing the board liaison role to the committee, and to maybe provide some more concrete direction. I think this really ties to what you were saying before about being explicit and what the asks are and where this work plugs in. So what do you expect from this committee? And we've had some really great feedback from board members over the last couple of months about how to make the charter for the new committee more tangible and more concrete in the things that you want to see this committee do and where you want to see them engage. I think we're going to continue to iterate on that over the next couple of months, and hopefully we'll launch by June. Okay, third is informing the development of those cost growth target accountability processes. So I think what we're looking for here is the board in a supporter role, helping provide some guidance and direction on possible options. So there are a lot of different ways that we can do this. There are, for example, a lot of different ways we could be thinking about performance improvement plans. And I think we would like to come back to the board later this year and share some of those options that we're thinking about, some of the templates that we're thinking about, and really look to you to help us think about what we might be missing, what options might be preferable, where there's connections with other pieces of work, and really help keep this coordinated so that we're thinking about accountability within the broader frame of all of these transformation efforts. And then last slide. Finally, just that ongoing role in reviewing the cost growth target reports and data, identifying those additional policy opportunities. So here we're proposing that the board is in a communicator role. So we really would love for you to understand what we're seeing in the data and what that means, both in terms of impact on equity, impact on other bodies of work and other board priorities, and helping make those connections for us, with us, across all of the board work. We know that as we look at cost growth drivers, we'll be looking at those in a variety of ways. We'll be looking at those across markets. So not just focused on Medicaid here, but Medicare, commercial, lots of connections back up to other parts of the work. And we really want to engage the board in this. Whether this is something that we do, again, going back to more of those educational webinars to set up deep dives into the data, or whether that's more of just a, hey, heads up, we've got some new information for you. And there's lots of different ways and levels that we can engage, but we're really hoping that this can be something we come back to you throughout the year with. And let me stop there. Diana?
I'm actually going to turn it over to Clarice. Thank you so much, Sarah.
Yep, thank you, Sarah. So board, this is, you've got the pattern now, right? This is your opportunity to weigh in. We invite you to think about how this conversation, this work around cost growth, cost containment is truly an equity issue, and how you parse that out, how you start to take that from our academic government brain kind of way of thinking about it, talking about it, and really engage folks, regular folks, we're not regular folks, regular folks. What are some of the systemic issues? Who might bear the burden of this? Who benefits from keeping it exactly as it is? How does that play into a class issue? And so we're opening it up. Those are just some things to get you going. I see Sandy's hand is up.
Yeah, this is to Jeremy. So healthcare is expected to grow 19.4% of GDP by 2027. So you've got 50% of projected spending growth is due to a rise in prices, 17% is demographics, and use and intensity is 33%. So with that said, what is not inclusive are inclusive in this data is the pandemic and some of the cost growth that is going to happen within the next 2 to 3 years. Long COVID, there's a lot of other health disparities that are going to be projected that aren't in the data that you're currently sharing. So what are you going to do for that portion of it?
Yeah, thanks, Sandy. You're absolutely right. I mean, there's gonna be a settling out that's gonna need to happen, and nobody knows exactly what that's gonna look like. Obviously, there's been huge payroll increases through Delta and Omicron, and I think folks don't really know exactly what that means long term and where they've been and what that ultimately is gonna mean in terms of trickling down to per capita costs. So I think that's the big question. I think as we've been thinking about the cost growth target, I felt like, even there's probably, I'm not saying it's a certainty, but there's probably a pretty high risk that we miss the target, at least one of the couple of years here during the pandemic. We won't really know till the data shakes out. But if that's the case, I think, we're really, the point of it is this is really sort of a long game. It's really trying to get that rate of growth under control over a stretch of time, and would expect that at any given year we may miss the target for a variety of reasons. Could be the pandemic, could be new treatments folks weren't expecting, and so the goal isn't to sort of say we're always going to hit the target 100% of the time. It's really to get the long-term average down, and to get us to better understand what's going on. So for, I think we would see the cost growth target program as the vehicle and the venue for us to have those conversations of what did the pandemic do in terms of costs, and recognize that still puts pressures on consumers regardless. I realize that there's always a tension there between what the healthcare system is trying to do to be able to provide care and also what people can afford. And so the point is really to create that venue for that conversation. But I think everybody's trying to figure out what this is going to mean long term, and we'll have to see. Although the thing I would just also mention is that in setting the trend numbers and recognizing we haven't had a pandemic like this, any of the data we were looking at, but we set the 3.4 and 3.0 trends. I mean, it wasn't us, it was really the implementation committee that was looking at long-term averages of economic growth in the state. So it was looking back out over the last several decades, capturing both recession periods and growth periods. And the reason for that was to say, again, we're trying to build a target that's based off of a long-term history of what the economic growth has been in the state, and to project that forward over a long period of time as well, and to be able to account for some ups and downs that would happen in the economy in the process.
Was recession included? You said recession was included in that?
Yeah, I think we captured at least two recession periods, and again, not a pandemic, obviously, but captured both a couple of strong growth years and a couple of strong recessions.
Bill?
I just wanted to add on to the great presentation Sarah gave. Sarah's been working very hard on this stuff, and there's many challenges. I wanted to follow up on the issue that Clarice raised. And I know we want to make sure is part of every conversation, which is how is cost growth, work the cost growth target committee affecting, either positively or not, our goal of achieving health equity. I think that's something we need to bring to the surface. At least speaking for myself, in the conversations I've had over the last 6 months or so with Sarah and folks at and Brenda and others about cost growth target. I don't think I have not brought up that issue as much as we should. It came up yesterday during the conversations with the committee folks and reminded me, and hopefully more of us, about the need to make sure this is part of it. Because I think we tend to think of like cost growth. Well, how does that affect equity? It's not directly related, but it actually is in many deep and fundamental ways. And so we need to make sure that's part of the work we do. The cost growth committee has a charter, and we're considering some modifications to the charter, not fundamental changes, but I think that'd be an opportunity to make sure we elevate equity appropriately and to make sure it gets built into the work that we do going forward.
Thanks so much. Yeah, it's a class issue, right? It's about people's money. So I don't know how we can avoid it. But thanks for that, Bill, right? Kirsten, I see you.
Yeah, and just to follow up on that, Clarice, I think it is a class issue, and because of the world we live in has such ingrained racism, I think this links very, very quickly to equity. I have two main comments. One, that as we go through this cost growth target work, that again, I'm going to keep using this, Director Allen's using green bars to hide the red ones. We need to make sure that we are digging deep here, and we talk about the industry as one. The industry has lots of actors in it. And so how are we holding up those who do have green bars, who made decisions during these times that really held up, prioritized patients or protected populations, and how do we identify when there are red bars and people who, maybe other systems made other choices, and I think that relates to like who raised prices for what reason, And so I encourage us to always go a layer deeper in what we are sharing in this process, because I think we do want to identify and celebrate those who are prioritizing Oregon communities. And then I wonder, to that end, I've been thinking a lot about how we talk about increase in costs as percentages. And so we think about the cost growth target as at 3.4% or whatever, but then I think about like an individual and their costs actually like aren't capped at 3.4%. It's like, you know, there is a premium cost for 40-year-olds of X health living in this area, right? But people don't have the same wages. So that fixed premium cost represents a very different burden based on someone's income. And so I wonder if we can seek to, when we make the implicit explicit about the link of the healthcare cost growth work to health equity, like, are there affordability metrics that we can regularly use to, and I don't expect them to change quickly at all because of this cost growth work, but can we use it to remind ourselves in the short term of why this work is important, and in the long term hold ourselves accountable to seeing progress on, whether that's kind of uninsured rates or underinsured rates, out-of-pocket costs, sliced by our Real D and SOGI, so we can push ourselves and hopefully see progress in those areas. And if we don't, ask why.
Yes, Kirsten. See, I even said it wrong. And I practiced in the mirror. Thanks, Kirsten. Yes, I think that's exactly the point. Wages, all of it is so interconnected, right? It's the intersectionality of it all. John and then Brenda.
Yeah, I just wanted to remind folks of an analysis I mentioned yesterday. Right now, we've got a commercial conversion factor of 170. We've got a Medicare conversion factor of 100. We've got a Medicaid conversion factor of 85. Basically, Medicaid and Medicare fixed prices. Commercial doesn't, as you can see. Well, what happens when there's that kind of disparity? A major factor in your success is avoiding Medicare and Medicaid. And what does that cause? It causes incredible stigma. You know, what we have heard in the Universal Task Force is low-income, vulnerable people feel stigmatized when they go into the delivery system, and they can feel from the delivery system folks that we're doing you a favor to take care of you. And, you know, you kind of need to get in and out of here so we can get to the people who we can make real money on. And in the analysis then that is subsequently done on what the impact would be of a quote normalized conversion factor, so it's all the same, to get rid of that disparity. The shift is billions of dollars, billions. So this pricing stuff is a huge disparity that is creating, you know, discrimination against vulnerable folks.
Thanks for that, John. I would add, you know, a piece about the elevation of Western medicine being the only way to treat the body, whether it's the body, spirit, and mind, to the exclusion of other traditional practices that don't get funded, that don't figure into any of the costs. I'm not pretending to have a really deep understanding of the mechanics of the dollars, but I do know that somehow that informs it. I do know that not being willing as a society to take into account other ways that we've kept people alive factors into this. So wanted to bring that to the table. Brenda.
Thank you. As I listen to the presentation and even to our reflections and comments about the topic, I'm struck by how critical it is to get after the individual's interest and reason why we should be compelled to lean into this work. Because I think different stakeholders listen with certain ears. You know, those that are small businesses have a very explicit why they think this ought to happen. I might be personally compelled and driven by things I've heard today or things I know in my own experience of serving uninsured marginalized populations, you know, in the work that I do. And I think, you know, I would urge us to be really disciplined to create those crosswalks. Here's a stakeholder interest group with a very specific perspective. Here's the compelling reason why for them, and to walk that so that we have enough kind of flexibility in our communications and our messaging to start where we are, you know, and to find it compelling. Because I think in this space, Clarice, your comment around, boy, oh boy, the obstacles that we are anticipating, they are significant and they are huge. And we are built to protect and preserve the systems that have been benefiting some. So how do we approach this from a perspective of, okay, how do we meet you with where your pinch points are, what your issues are specifically? And our communications is so disciplined and spot on that we overcome the obstacle before we come straight into it. Because if I use health equity definition, redistribute power and resources as my lead, I may find some resistance that may not be strategically the most advantageous. It appeals to me. It may not appeal to the person who's listening to me. So I just want to be thoughtful about that.
Absolutely. And these conversations, right, are bringing it more and more and more into focus, more and more into creating the concrete things that you actually can do that get at least some movement. Yep. Sandy.
Yeah, just a quick question to Jeremy. So in Q4 of 2020, were you able to hold a dry run cost hearing? And then moving on for this second quarter, you're going to, you know, you publish specific specifications and data submission requirements, and then payers and providers submit a calendar year 2021 data to OHA. You review that data in the second, third quarter with those providers. And then first official cost trending hearing, compare calendar year 2021 performance to the cost growth. Is that going to occur? Are you going to be on target on that?
So the short answer on the first one is we did the hearings coming up this Friday will be our first. We were shooting for the fall, and then Delta happened, and then we were shooting for the beginning of the year, and then Omicron happened. So this will be the first. I'll let Sarah maybe walk through where we're at in terms of data submission timelines. And we knew we will not have data for this for the first year for this this Friday. We're using some other data sources and sort of try to do this the first time without the focus just beyond did we meet the target or not. And we'll do that later, a second one later in the year. We'll be looking at the 2021 data. And part of that's just, we knew that this first year was going to have a longer period of time to get data validated and sort of in the process. We expect that to shorten in the future, but we'll let Sarah fill in some details there.
Yeah, so in terms of the data submission template requirements, all of that, we met our initial goal. So every year we will publish an update to the specification, the manual, any changes that are made. That will be published several months before the data submission is due. That's a lot of work with our technical advisory group that I mentioned. So we met all of those timelines in summer, fall of 2021. And the data submission, our first data submission was submitted in October of 2021. As we mentioned before, we've been validating that data. It was the first time, it was a big lift. And so we've been doing a lot of back and forth. We have some stats, and I think maybe all but one or two of our data submitters had to resubmit their data at least once. So there's a lot of nuance in putting that data file together, and validation has been complicated. We are already working on the updated data specification template and manual for 2022. We are sharing that with our technical advisory group, actually probably next week. So the draft will be out this month. The final will be published in May. We have this annual cycle where we send an official notification to all of our data submitters and say, based on how many covered lives you have in Oregon, you are an official data submitter for this program. Here's your timeline, here's the manual, here's how to engage with us, here's the support we provide as a team. And as Jeremy said, we're hoping to shorten that timeline. So this year, the data submission is due in September. So we're moving it up a month. It'll be September on an ongoing basis. And then depending on how long validation takes, we will then be able to start publishing data out of that report. Hopefully by the end of the year. It may carry over into early next year, depending on when, just depending on how complicated the data submission is and how much back and forth we have with our submitters.
Oh, just a question, then just a follow-up question on that. So then if a lot of your providers weren't seeing patients, so I mean, it's going to really mess up your data. Hospitals were overloaded. Providers were shut down, whether they were doing telehealth or telemedicine, whatever. But it's going to skew your data. So I'm just curious for FY21, well, even 20.
Yep.
How that's going to reflect with providers. So
absolutely. And that's part of why this is a learning process as we go through validation. So all of the data submission that we're talking about comes from payers only. Providers do not submit data under this program. So we have a multi-stage process where first we go back and forth with the payers to make sure that all the requirements have been met. We understand the data, that there aren't any errors in the file itself, that we understand what the data is showing us. We have a 3-stage validation conversations with the payers, make sure that's all sorted out. As part of those conversations, we identify interesting trends, outliers, things like, oh, it looks like there was a huge dip here. What happened? For example, utilization dropped because of COVID. So we're able to have those conversations with payers, and we have a really long process. And Cindy, I can share some documentation with you that sort of goes in much more detail about how we do all of this. But after that, what we're about to start, we haven't started yet because we've been focusing on that payer level. And again, with the Delta and Omicron waves, we've been holding off on direct engagement with provider organizations. But that's the next phase, is to go to all of the provider organizations that are identified as accountable under this program and to say, here's what we see in the data. Let's have that validation conversation. Let's understand what the cost growth drivers are. Let's understand what was happening in this period. And we have a whole list that our former implementation committee helped identify of there are lots of reasons why we might not meet the target in a given year. That could be COVID, that could be something else. We know that sometimes benefits change, benefit mandates change, new drugs enter the market, lots of things affect what we could see in any given year. So we do intend to have conversations with the provider organizations, understand what they're seeing, and get to that point before we do any of the reporting. So it's a pretty labor-intensive process. One of the reasons we've talked about a dry run hearing, and we're doing this first hearing on Friday that's not focused on that performance data, is just because we have phased in implementation. We want to make sure we really understand the data. We want to make sure that we have payers and provider organizations that are comfortable with that process and that conversation before we start publicly reporting anything that we don't have confidence in.
The only thing I would add is, Sandy, is we did, the implementation committee, like really to their credit, agreed to submit data back to 2018, I think it was. So we would have data before the pandemic, not that we're holding folks accountable, but we could then compare what was happening during the pandemic and what's happening on the other side of the pandemic.
We do expect later this year, next year, to be publishing some reports or briefs, data briefs on the impact of COVID and what we're seeing. So we definitely want to be digging into that more, and we'll certainly come back to the board with that as part of that data sharing that we talked about.
Thank you. Sorry for taking up so much.
Thank you, Sarah. Thank you, Jeremy. Thank you all for the questions. This data thing is a complicated game, you know, right? And useful. We're gonna move on. We're at almost 1:15. We have about 45 minutes left in this container, in this space. We're gonna move. Diana, is this?
Sure. Thanks, Clarice. We're going to move to health coverage. And I know we similarly, like we've just done, we have a short presentation and then for some discussion, time for discussion. So let me, I'm not sure, I think it might be Lori Coiner or Jeremy, not sure who's doing the presentation on the coverage piece. Is it you, Jeremy? Okay, go for it. Hi, Lori.
That was Tara just sharing that it was Lori, but I see Lori is on.
All right, take it away, Lori.
Hi, everybody. Sorry, it took me a minute to get off mute and get on video, so apologize. And this is not on coverage, but an update on our 1115 Medicaid demonstration. And for many of you, you've heard a lot of this before, or this is just an ongoing update that we have on the Medicaid waiver. I have some brief slides and yeah, then we can have some discussion. So next slide. Just to ground you in where we are on our timing, I was thinking about this yesterday and have been working on the waiver a year now, and we have many more months to go still. So the final concept papers were released in November. We had public comment. The waiver was, our 1115 waiver was posted for public comment in December. We received lots, and I don't have the total numbers, but we did receive a lot of public comment. We're really excited about that because we received comment from members, from organizations that work with members, community organizations, the provider community, advocates, the delivery system. So it was, we received public feedback from, you know, a really wide array of folks. And I think from my perspective, that means that we have a lot of people who care, and for the most part, our public comments were positive. This reflects the fairly, you know, intensive work we've done up to this point on getting, you know, public feedback before we finished, you know, a draft that was posted in December. We incorporated public comment. We submitted our application to CMS, the Center for Medicare and Medicaid Services, mid-February. We received notification from them that our application is complete, and they posted the waiver for federal public comment, and that comment period is happening now. The last day to submit public comment through the federal public comment period is April 13th, so next week. We also started negotiate, I would call them at this point discussions with CMS in the beginning of March. So about once our application was complete, they began in earnest. We are meeting, we've been meeting once a week. We are stepping that up to twice a week here in the next couple of weeks. And really this time period, what we're doing is talking about, they want to know more. They're asking lots and lots of questions about all of our policy ideas, and not really giving us an indication of, you know, thumbs up or thumbs down, but gathering information so that they can start to put together their own internal policy papers to send around to federal partners. We are anticipating an extension that will go so that our waiver would be extended till the 1st of September. And then what we would do is have from the 1st of September till the end of December, 120 days to wrap up pieces that we didn't get completed, and you know, with CMS, and then start really implementing the new waiver changes the 1st of 2023. Next slide. Just to remind everyone about our big policy focus areas. The overarching goal of our waiver is to advance health equity in Oregon. And to achieve that advancement in health equity, we have 4 big major policy areas. So one is to maximize coverage and through the Oregon Health Plan. So the two, I can't remember. I'll talk through them, and I'm not going to advance slides. I can't remember if there's slides on each of these topics or not. The two big initiatives there are, one is to, we're requesting continuous coverage for kids up to their 6th birthday. So if a child enters Medicaid anytime from whether birth or let's say at age 2, they would have continuous coverage all the way until they're 6. And then we are asking for 2-year coverage for every health plan member Oregon Health Plan member who is 6 years and older. We've learned a lot about what happens when we allow people to have 2 years of coverage through the pandemic. And we believe that this will eliminate lots of what we call churn, where people fall off their Medicaid coverage and then come back on. So this is to kind of stabilize that coverage so that people can access healthcare more continuously. The second big focus area is improving health outcomes by streamlining transitions. What this means is that we have a number of life transitions that people go through. And in those transitions, they often lose coverage. And so we're asking for coverage before folks leave criminal justice system, before they leave the state hospital, for youth in the Oregon Youth Authority, or youth who are leaving foster care, for example. And then we've created transition packages which are focused on social determinants of health. So housing, employment, food assistance for those folks that are transitioning, so that they have access to really the things that they need to lead a healthy life and cover basic needs first. The third is to encourage smart and flexible spending for health equity. And the big area here is the focus is on allowing these social determinants of health services to count as medical expenses for the CCOs. The reason this is important and tied is because then we can have the social determinants of health kind of packages that we're talking about become benefit-like, meaning that there would be equitable distribution of these services across the state, and that CCOs would, it would encourage their spending on social determinants. We do believe that when people in transition are given the basic needs, to be healthy, that we will eliminate medical expenses like unneeded emergency department visits and so forth. And there's been some recent publications, for example, in Multnomah County that did demonstrate this and showed really big decreases in medical spend just by providing people leaving criminal justice housing. And then the last area is focused equity investments. And we are proposing that we create or that community investment collaboratives will be created throughout the state. These would be community-led and community-driven. The lead agency of the collaborative needs to be a community organization. We are asking for extra federal dollars from CMS to fund these community investment collaboratives. And the real focus of them is to improve health equity right within their community. We've been really lucky to have a great partnership with the regional health equity coalitions in, developing, what these would look like. And we're in the middle of conversations with CMS about funding for that. Next slide. This just lays out, I think more of what I've said, so I'm going to breeze through it pretty quickly. like I said, we were notified that our application was complete on March 3rd. We're in the middle of public comment period. March through May, we're having these detailed conversations with CMS just to provide more detail. We're answering lots of questions. That, you know, then that'll be an iterative process all the way until September. And then we finalize the details of the waiver agreement, you know, September through December. Next slide. I guess that's it. So want to see if there's any questions, comments, thoughts. And I'll turn it back over to you, Diana.
Thanks, Lori. Questions from the board, comments? I know that this is an area where the Health Equity Committee and the Medicaid Advisory Committees have been very involved and will continue to be involved. From a board perspective, I think, you know, there's a question again, and Lori pulled a lot of this out, obviously, about how the waiver moves towards health equity and eliminating health inequities. But just want to see if there are specific questions or comments that the board has in terms of its work related to the waiver and coverage.
Lori, I know that, you know, for community engagement and community input is really important for the waiver. And I know that this time around, the pandemic really kind of challenged that opportunity to do that. I'm just kind of curious to hear about your thoughts, you know, like already for the next waiver, which may feel like a long time away, but like improvement, like systems improvement along like integrating and ongoing community input, community engagement, particularly with, you know, like the additional staff that the Office of Equity Inclusion is getting, and as well with the, you know, the public health department.
Yeah, great question. A couple of thoughts come to mind. So on the community investment collaboratives, the Office of Equity and Inclusion is really leading that work within our agency, and, you know, meeting with partners to help collaboratively build that program. So that's happening as we speak. For example, last week it was on the topic to talk about with CMS, and we were able, the OEI team was able to meet with the RHEX, the Regional Health Equity Coalition folks Tuesday before to help answer the questions. So I feel like that's been a big improvement in terms of involving community in our development. But I also acknowledge that we can continue to improve, and there were pieces that made it difficult with the pandemic to get as much community input as we can. We've worked on a equity impact assessment to take a look at our process. You know, more to come on that, but, you know, to identify where we did a good job and where we have more work to do in terms of bringing the community in the process. And we'll be taking a look at that, you know, to assess, just like you said, for the next waiver, on how we can do a better job and where, you know, areas where we really need to focus. So appreciate that conversation or that question a lot.
Thanks, Oscar. Thanks, Lori. John.
Yeah, well, you know, I think at times like this, it's important to acknowledge history. I think 4 or 5 years ago at a retreat, we were talking about what Governor Brown wanted, and she wanted more focus on children. And I think OHA has done that in this waiver, and then in resolving some controversies. And there's some more out there about children. But I just want to acknowledge that something OHPB has been very involved in the past, has in many respects gotten done, I think gotten done well. And OHA has been willing to listen to advocates for children and respond to them. And I just want to thank you for that. You know, since we're facing a transition, it'll be interesting to see where children are in the next, you know, administration, and we just shouldn't forget about them. Thanks.
John, thanks for calling that out. And it also reminds me, I think Kirsten had said at one point in discussions leading up to the retreat about the long arc of the work that the Health Policy Board has been engaged in doing, and that in the waiver application and all of this work, you are seeing in many ways some of the conversations, the fruition of some of the conversations that the board was having 2, 3, 4 years ago. So, and appreciate that, pulling that out, and Kirsten's comment about that. David.
I want to acknowledge that there was a robust discussion between the HEC and the waiver team regarding community input. And I think a lot was learned. I think OHA responded really well to that. I think there'll be lessons for the next waiver, as Oscar rightly says. I also want to remind the group that my understanding of the waiver is it gives OHA permission to move upstream to power share with community, and to do a whole lot more than just pay for services, medical services. And that I would think the community input between waivers that the waiver allows is probably the most important input. Then the waiver, community input during the waiver process is important, but it's focused on the community input and power sharing between the waivers that will be most important and guide OHA's work.
Thanks, David. Any other comments or questions for Lori or about the waiver? Okay. Lori, thank you so much. And as we sort of move towards the end of our time together, just in this retreat, we're gonna, Clarice and I, as we sort of get to the wrap up at the end, we'll spend some time sort of going through some of the major themes and some of the next pieces of work. So we'll be doing that towards the end. For now, what we wanted to do is sort of transition to a conversation about transition. And that this has come up a number of times in the conversation around all the transitions that are happening. And obviously you have one with the board and the chair and the vice chair. So I want to turn it over to OHA to give us some time and space to acknowledge the leadership transition, and we'll spend some time there before we come back to a wrap up of the retreat.
Sorry, I momentarily lost consciousness when Oscar talked about the next waiver. This is an opportunity for us, I think, to do a couple of things. And the first is to thank David Bangsberg for his service as the chair. If we were in a traditional meeting where we were all in person, we'd be able to, have him stand up and make him feel embarrassed, and we'd give him a letter from the governor and a certificate. Those are in the mail, David, given the fact that this is a remote meeting. But I just wanted to thank you for your unswerving dedication to the work of the board. I think your commitment, not just to health equity, but especially to health equity, and to all the things that the board does and oversees, I think has been an incredible help to the agency and to Oregonians generally as we try to move forward to make sure that all Oregonians are able to be healthy in the communities that they live in, and that we're able to move forward to achieve health equity as we've talked about in our strategic goal. Jeremy, let me toss it to you, and then we'll open it up to board members for a moment of reflection.
Thanks, Pat. Yeah, I also just want to echo David. I think you've been an incredible leader on the board. It's been great working with you. I know the team has really appreciated working well with you and Oscar as chair and vice chair. Although we got to keep working with Oscar. And I just, I think came in at a real pivotal time with the board with CCO 2.0 and picking that up and leading us through a pandemic that we didn't know how long would last and how to navigate virtual meetings, and that need to navigate balancing what work would need to slow down or speed up. And I think your commitment is going to show not only just in the fact that we have a full board and a lot of excitement and, you know, I think a great energized retreat, but also all the work ahead, and we'll continue on. And so, you know, I think what folks probably don't know is, you know, I think is David behind the scenes really had a commitment, I think, to saying, like, trying to get the board to the next phase of what it will be, and really functioning really smoothly, and board members really making sure that they knew where their place was, and felt really comfortable and felt able to bring up issues, and making sure we're really practicing equity as a board itself. So I'm forever grateful for you, David. I'm super excited to hear about your next adventures, and sad to not just be losing you from the board, but from the state. And thank you for your commitment.
Before we turn it over to David to say a word or two, I wanted to open it up and see if any board members wanted to offer any comments or reflections. Brenda.
Yeah, thank you so much. And David, just thank you. Your leadership for this board has meant a lot, I think, to me personally. And one of the things that I appreciate so much about you is the way that you can honor complexity, public testimony, consistently think about the voice of public health. You know, as a former public health nurse, I always can count on you to, like, bring, there it is. Yep, there it is. David's got that in play. And I think to supplement what Jeremy and Pat are saying around the evolution of the board itself under your leadership has been really noteworthy. So thank you. And I also wish you the very best in what's next. Yeah.
Bill.
As a relative newbie to the board, I just wanted to offer my thanks. Also, congratulations to David on his next stage of his career and life. But I want to particularly thank you for your leadership you've shown. I didn't know you, or hadn't had a chance to work with you before, but the leadership you've shown over the 9 months I've been on the board has just been outstanding. I think particularly making sure that everyone is heard, managing the process in a way that is inclusive, but also gets things done. And I really appreciate your leadership. Really wish you the best in the next phase.
Thanks, Bill. Ebony.
Yeah, I just want to say I too appreciate your leadership. I'm sad that I don't get to, work and learn and walk alongside you, for more time. But, in the short period of time that I've gotten to know you and had opportunities to, just be in conversation from, perspective of the work that we do on the board, the work that we, are charged to do locally within Multnomah County, I just appreciate your guidance and your leadership. As I stated earlier, I joined, I think, in the middle of the pandemic. And, one of the key things that, stood out was your willingness of how you reached out to me as a new board member to just check in to see how I was doing and to just be a support. And, I can truly say too that, you truly live out your values as seen not only with what you talk about in these meetings and our board meetings, but also, again, the local work you did relative to the school and Multnomah County. So I just want to tell you thank you and congratulations.
Thanks, Ebony. John.
Yeah, David, you and I came to the Oregon Health Policy Board on the same day. And so I think I'm uniquely qualified to say, wow, have you made a big difference? You have just made a huge difference. As you get older, you look back and the times that really things got as bad as they could get, and you got through them, are the ones you are most proud of. And you deserve to feel good. Things got really bad in 2020, and you were terrific. And thank you so much.
Kirsten.
I too just wanted to add to the sentiments of gratitude. I feel like I've learned so much from you, David, and I've appreciated the different kind of levels of approaches that you've brought to work, because I feel like I've learned from you as a person, and had a great time on our field trips, like hearing about other parts of your life and experiences. But also I think in this pandemic, you thoughtfully saw us as board members and people, and not just the board, but like all of those involved in OHPB as both, yeah, as people during that moment. And I think that showed a lot of leadership and love to just be able to create that space to give to others during that time. And then I also have admired how you bring your expertise in public health to this space, which is so necessary and valuable. But you brought that expertise in an equal amount of curiosity and willingness to learn in other areas too. And so I hold it up as a model for how we can all be board members, bringing our expertise and also curiosity to grow and learn and support in new areas. So thank you so much and good luck.
Thanks, Kristen. Oscar.
David, I just want to say that working with you has really been a gift, a personal and professional gift that I'm going to carry with me as I move forward in my career. I just want to thank you so much for the type of leader that you've been. You've been a very knowledgeable leader. You've been a kind leader, and you've also been an accountable leader. I think we have been, as a board, and OHA has been very fortunate to have your leadership during this pandemic. It's been really interesting ride. I think we've definitely had some moments where we're like, ooh, that did not feel great, or that did not go so well. But I've really enjoyed just like, your thoughtfulness, your reflection, your desire to make things different, to make things better. It's going to be a huge loss. We're really going to miss you on the board and as a statewide leader here in Oregon for public health. So thank you. And big shoes to fill for sure.
Thanks, Oscar. David, I think in what should be one of your last opportunities to speak without having been called on, let me turn the floor over to you.
Okay, well, thank you. I shared a few thoughts at the beginning of the meeting yesterday, and just think of 3 notes of appreciation deserve underlining. One is to all the Oregon Health Policy Board members. I have learned so much through the thoughtful, generative discussion with everybody bringing their areas of lived experience and expertise to the discussion in a really open and constructive way. I've learned enormously. I'm very grateful for that. And I feel really, really good, really fabulous that OHA is in great hands with all of you, and they've never been in better hands. And so it's a good time for me to step down because y'all are going to really support OHA, nudge them in the right way, in the right direction, and make OHA even better than it is today. So thank each and every one of you for my learning opportunity. And I also would like to thank OHA staff. Between being on the FAB, being on the HEC, being on this board, our weekly 8 a.m. meetings, and discussions in between, you get to know the OHA staff pretty well. And, you share moments of frustrations and when things go well and things don't go well, and you reflect and you sort of revisit and say, okay, well, where should we go from here? And I've never met a group of more mission-driven, committed, intelligent, evidence-based people who just show up and serve the public so well. And that's really amazing, especially in these times, just to see civil servants and leaders really do a superb job. And that's at every level, every single level. So thank you for that. And with these weekly calls, I got to know Oscar pretty well. Yes, when some things go well, some things don't, we would get on the phone and say, oh, well, how do we handle that? Where should we go? Brainstorm with OHA staff. Sometimes Oscar and I are brainstorming with each other and just teaching each other and learning from each other. And you're in really good hands with a very effective leader who's very committed to health equity, who's very generous in his leadership style. And I think you're going to do great. You're doing absolutely fabulous. Better than you've ever done before, better than you ever did with me. And you might see my name on the Zoom call from time to time, just as a citizen, cheering you on quietly and celebrating the great work that you will continue to do for a long time to come. So thank you. It's been one of the most profound joys and honors of my career just to work with all of you.
Thank you, David. Sandy.
Yeah, I just wanted to briefly mention, I'm new at this, David, and I do appreciate all you've done over the years, and that I hope I can uphold to your performance standards. But I do thank you. I know you came here to Umatilla and we got to meet and look at what's going on here, but you're a great asset, and I appreciate all you've done.
Y'all going forward, yeah, one thing I hope you do is get out of the Zoom environment, get out of the Portland, see the state. That was so much fun. I know several of you joined, were on those field trips, and I hope for a day where you can do that again, because there's so many great people doing great work around the state that it's really important to see firsthand, and I wish that opportunity for you.
To wrap things up, let me, on behalf of all of us at OHA, and especially the team that worked most directly with the board, welcome Oscar Arana as chair and Kirsten Isaacson as vice chair, and turn it over to the two of you for any comments you'd like to make.
Kirsten, would you like to go first?
Nope, I'll just say that they are big shoes in the vice chair as well. But I'm honored and excited and look forward to the charge ahead. Oscar, take it away.
Just really quickly, when I joined the board six years ago, same day that Brenda joined too, so I remember that. I never imagined I'd be stepping in as the chair of this board. I remember the first probably 6 to 9 months, maybe even up to the first year, having these huge packets of materials that I was like, I don't know how I'm going to get through all of this information. So I'm just really, honored and grateful for the trust of the fellow board members and the OHA leadership, and the governor for trusting me in this very important role. I will take it very seriously. I'll be thinking about David's commitment in this work. So yeah, I know I'm really looking forward to working with you, Kirsten, and we have a lot of work ahead of us. So can't wait to start getting on those calls and text messages too.
Oscar, the secret. The secret is to do whatever Tara suggests. Tara Cheetalk suggests you do.
Yes, definitely know that for sure.
Well, Oscar and Kirsten and all the rest of the board, we're certainly looking forward to working with you all in the coming transition. And with that, I will turn it back to you, Diane.
Thanks so much. And thanks for all of those comments, and really honoring David and honoring all of you, and setting up Oscar and Kirsten as they move forward into this work. And as we wrap up, what we've been doing for the last couple of days is really talking about the role of the board and your work and what you've done and where you want to go and how you work with the agency and the committees. And what I just want to take a minute or so to sort of call out some of the themes that Clarice and I heard, and then we'll talk about next steps and give you the opportunity to weigh in as well. But really, we started the conversation with committees yesterday morning and thinking about how all those groups come together to drive towards the 2030 goal and really how to address health inequities and work on anti-racism, and how do you support the agency and give cover to the agency, as we talked about yesterday. And thinking about the importance of relationships that came through again and again, not only board committee relationships, but across committees among the board. We just heard about that, and then how the board works with the agency. Another theme, and I think it was demonstrated by all of you, is speaking authentically and having courageous conversations and discussions with each other and within the spheres of influence that each board member has. And then a fair bit of conversation about really how do you directly address resistance and obstacles and taking explicit action to address them, regardless of the level on that systems triangle or iceberg. But that really trying to, and sort of coming back under to the bottom of that iceberg is how does that work? How does that work happen? And where does the board call that out? And pieces about the committee, in terms of the committee work, sort of there's membership work group had some recommendations, and how do you move those, the recruitment efforts being really important, and then how do you move that to shared power, and how do you find and have that conversation and take that action, and where's their alignment across communities, and where the committee is looking to all of you to give them some direction. And just as a side note on that, there was some discussion about maybe it's time to ask all of the committees to revisit their charters. So that may be one of the next steps pieces. And then just on cost growth, as well as sort of the waiver application and coverage, is continuing to think about how does this work address health equity, and being clear about why and how this work is important to all of the stakeholders. And then came through in a number of the questions and comments that, how COVID has impacted this work, and its shadow continues to impact the work, and how are you all thinking about that, and how do you want to be working with your committees to be thinking about that. So that's a lot of words, but it's just wanted to pull through some of those pieces and keeping, and this came up again, and keeping all of this really focused on that 2030 goal. And how do you tie it all together when there's so many different things going back to. And I'm going to turn it over to Clarice to just talk about next steps in terms of some of the concrete things that'll happen, and then do a final wrap up, and then we'll hand it to Oscar to do the final wrap up. Clarice, please.
So that we've all, the staff and Diana and I, when we weren't talking, we were writing notes, typing notes, trying to capture as much of what you offered as possible. So we'll be getting back together and synthesizing, going through, trying to figure out, make sense of our own personal shorthands to bring back, to give back to you any pieces that seem, all of the pieces that seem so relevant to the work that you're doing. Wanted to put a note around the reviewing the statute that established the OHPB as one of your first kind of muscle exercises to change that, to see how you can be appropriately sized to support the amount of work and the committees that are out there doing the work, which again, probably puts you dead in the center of a succession planning conversation. You know, the retreat is this annual retreat. I'm grateful for having the opportunity, right? This was my first rodeo with you all. I'm grateful for this opportunity. Such an intentional act, I guess, to step back and to think about the work and think about where you've come. And you have such an opportunity, it seems to me, to make really sustained, deep change in Oregon, in the health of Oregon, in the health of everybody in Oregon. And that your sustained effort looking at the historical practices that are racist, that have marginalized people, set such a standard for the other systems in our public sector, right? In our public human service sector. By clarifying, by being really clear with the committees about what you hope for, and they become, you know, the community that you are engaged with, right? Just like the committees engage with the multiple communities out there, the committees are your community. So you have to hear from them, their struggles, and be with them where they are, and move with them. And I think the framework, the iceberg, gives you a model. If not that, find one that can help you keep your work going, that gets you to go deeper and deeper. And from as many dimensions as possible, right? That's the notion of the determinants of health and intersectionality, that there's no one line on this. It's all dimensions at the same time. So how do you sustain yourselves? How do you find the relationship among yourselves to sustain yourselves? I think that Diana and I wish you the absolute best as you walk out of here. And so thank you for letting us be on this part of the journey with you. I'll give it over to Oscar and Chair, what you got?
Well, thank you, Clarice and Diana, so much for such a wonderful facilitation style that you brought to the retreat. I just felt like your partnership and your collaboration was really thoughtful. It was very relational and intentional. It was a really successfully facilitated retreat. So thank you both so much for your work and for moving us through these last couple of days together. I want to also just thank the OHA staff and leadership for all the work that went into putting this 2-day retreat. I know that, you know, it feels, you know, in a way very effortless, and in order for it to feel effortless, it means that there's a lot of work that occurred on the back end for us to get to this point. So just want to thank OHA leadership and OHA staff for all the materials and for getting us to this point. I also just want to acknowledge and thank the committee members who were here with us, you know, for their time as dedicated volunteers, for their time in their service on the committees, trying to move this really important work. And I want to thank my fellow board members for all your dedication and your service and your excellence and your dedication in this work as well. I'm really humbled to be part of this board, you know, with such a wealth of information and knowledge and experience. So I'm just so grateful to be a part of that. I think Diana and Clarice did a really wonderful job of sort of, you know, listing out the takeaways from the last couple of days. So I'm not gonna, you know, kind of list my own because I think that they did a really great job at that. There is one more that, you know, sort of to me stands out, and that's the importance of inspiring this vision you know, not just within a few folks, but inspiring this vision about this work throughout the agency, throughout the committee's work. And, you know, understand at the same time, like the challenges of moving forward in a pragmatic and practical approach as well, right? So continuing to have that vision, but understanding, you know, the operational challenges that are going to get in the way. So being really thoughtful and being very careful about what actions we actually decide to move forward and that we actually prioritize. So, and, you know, I know that we're probably gonna like make some missteps along the way, but we will be reflective and we will be thoughtful and we will be willing to change. So yeah, thank you all so much for your time and your dedication, and looking forward to our May board meeting. So thank you.